My name is Göran Thomson, and it's my privilege to be chairing this session. And this session is something special. You know, in health systems and health systems research, we always talk about the importance of context. So now we have the privilege to have presentations from 2 African countries, 1 European country, and 3 Asian countries. And I will present very briefly the title and the presenter as we go along. To the presenters, please keep time. I'm not going to be a police. I'm a little bit known for having red cards and warning people that take more time. But I'm not going to do this. The ambiance is too nice. But if you take more time as presenter than you have allocated, we will have no time for a panel, and I think that would be a shame. Right, without further ado, and as I see that Faith Agbozo from Ghana is ready, I'll invite her to talk on climate change and pandemics compound the existing healthcare inequities in Ghana. Floor is yours, Faith, please.
Yeah, thank you very much, and good morning to us all. It's a great delight to be here again in Heidelberg, and I've lost my heart in Heidelberg, or rather I have deliberately left my heart in Heidelberg, because it's always very nice to come back. And I want to say thank you very much to Albrecht for his support during my PhD period, and he didn't abandon me, and he has been supporting me since I finished the past 2 years, so that's very tremendous. I come from the University of Health and Allied Sciences in Ghana, and I want to mention that the university is state-owned and just 10 years old, and just 2 weeks back, we named the School of Public Health where I am after Professor Newton, Fred Newton Binka, so it's the Fred Newton Binka School of Public Health. And some of you might have known him. He's a renowned epidemiologist and also the first vice chancellor and the founder of the INDEF network. So we are making strides despite the small beginnings. I want to talk about climate change and pandemics and how we see the health system evolve with the current COVID-19 pandemic. I want to also mention that I haven't been active, I haven't done research in climate change until this year when I got a postdoctoral fellowship that I'm working with INA, and then we are looking at climate change adaptation as part of the African Climate Change Initiative through the DAD scholarship. So first, I want to talk a bit about the health systems in Ghana. Please, it's not moving. So I want to highlight a bit on the health systems in Ghana, and to say that Ghana is one of the countries within the sub-Saharan Africa region that is making quite some progress in terms of the healthcare system. And we see that some of the key issues that are of interest that I want to share before we move to the main substance is the fact that we have a near perfect universal health coverage, and that has worked strongly through our community-based health services and planning system, which we call the CHIPS concept, and for which every primary care level healthcare is quite robust, such that in the smallest and remotest communities, you find over 30,000 community health nurses that are deployed across the nation, so healthcare is pretty much accessible. Another key strength also is the skilled human capital training in healthcare. And I'm glad to also say that we have reached the nurse to patient ratio for as recommended by the WHO. Another strength of the Ghana health system is our health data management. We have the district health information management system where all the health information is nicely coordinated right from the lowest level to the highest level. And we've even made a further progress of moving paperless in terms of healthcare delivery, such that At the OPD, the nurse can provide your record and you can walk straight to see the doctor without having to carry any paper. I'll mention is our National Health Insurance Scheme that has reached over 70% of the population. And we have the free maternal health care where every pregnant woman receives health care for free. And also we have the health insurance scheme again extended to the very poor and the aged through the Livelihood Empowerment Against Poverty program. So the health reforms that we see, the 4 main health reforms have yielded dividends, but the key one is the linkages and empowerment of communities to be responsible for their own health care. Now I want to talk a bit about climate change, and within this past few months, I've been looking at the climate change landscape in Ghana. And we noticed that, like for all other countries, there's obviously a change in the climate, and between the 1960s till date, there have been, for instance, a 0.2% increase in temperature, and sea levels have also risen, and precipitation has also increased by 2.4%, for example. And it is projected that within, from now to 2080, we are going to further see high levels in the sea, and such that it's going to rise up to 34% thereabouts. Again, temperatures are going to rise up to 30 degrees or even more, and there will be variabilities in rainfall patterns, and the variability will be such that the north will experience less rains and the middle and the southern belts more rains. The implications of this effect is what we are already currently seeing, that we have tidal waves, and just this year there have been tidal waves across the south western part of the country that has displaced many communities. And we also see the national capital, Accra, has experienced torrential rains that has caused flooding across the capital. And there's one key problem, the spillage of the Bagri Dam, and it's an annual affair. The Bagri Dam is in Burkina, and it always overflows its banks, and every year they have to spill the dam, and then it causes flooding within the northern belt of Ghana, and that gives also this internally displaced persons and this climate migrants. Then we see also with drying up of water bodies and of our rivers, and that is leading to drought across the nation, especially within the northern belt. Now, in 2020, the World Food Programme launched the comprehensive food security assessment, comprehensive food security and vulnerability assessment, to see how the nation was responding to the COVID pandemic and also to the shocks that were associated with it. And as expected, it was noticed that over 60% of the populations, and this survey was done in over 6,700 households across the country. And COVID impact was felt in over 60% of households. And high food prices affected also over a third of households in Ghana. But there is one important thing that I want to mention, the direct impact of climate change, which we see as variability in rainfall, crops and pest diseases, and animal disease, zoonotic conditions, as well as bushfires and landslides, affected over 42% of the population within 2020. And the key effect that this has caused is food insecurity, and that is one of the first inequities that we see across the nation is food insecurity. As we speak, 11.7% of the Ghanaian population are food insecure. And we see some differences within the distribution of the food insecurity, such that within the households, male-led households, interestingly, are more food insecure when you compare to female-led households. You see male-led households have 20% food insecurity as against about 16% in female-led households. What is also important to mention is that the communities that are involved in food production, so we see among livestock farmers and among crop producers, they are highly affected by the food insecurity problem. So from the source where the food is coming from, they are the ones who are most food insecure. And that is something that gives us a cause for worry and something to also think about as we move forward. I want to mention food prices because a third of the population mentioned the shock from high food prices as the biggest problem. And this, I hope, is a little clear. We see the first. This is, we have Ghana, and then we have Burkina, we have Togo, Ivory Coast, Niger, and Benin. And what I just want to mention in terms of food pricing is that West African region has experienced a torrential increase in food pricing when you compare to the other sub-regions in Africa. And if you see, the increment has also gone up for indigenous foods. I'm talking about maize, millet, sorghum, and cassava. So when you look at the graph, you watch, and this is from the World Food Program market survey that was done just this first quarter of the year. You realize that Ghana and Togo seem to be on the high radar for high food prices if you compare the rates in 2021, which is the blue line, and then 2022, which is the red line. And you can see that the trajectory for Ghana and Burkina Faso, for example, is very steep for millet and for rice. We can do a bit of price comparisons for Togo, Burkina, Benin, and Niger because the currency is the same. And for example, if you look at Togo and Benin, where the commodity is also the same, corn, you see that the price increase in Togo is double or triple. I think it's even triple or more higher than when you compare to Benin, who are just neighbors. And now let's look also at some key healthcare indicators and what has transpired before and after the pandemic. Data sources are a bit problematic, but fortunately we have some data from the multiple indicator cluster survey and again from the food security survey that the World Food Program conducted. Though they are not very comparable, but we can just see some form of trajectory also for healthcare indicators. For example, coverage for vitamin A supplementation and other immunization programs have marginally gone down. We also see service uptake for antenatal care and skilled birth attendants has also gone down when we are expecting an increase. And also is health behaviors in terms of early initiation of breastfeeding. What has marginally gone up is exclusive breastfeeding. But the biggest worry for us is diarrhea diseases, and we see over a threefold increase in diarrhea diseases when you compare the data in 2017 to 2020. And most worrying, a double-fold increase in neonatal mortality rates. That has been associated with the pandemic. Now, I also want to talk about education because it also has influence on human capital and invariably also on health-seeking behaviors. And in many places, there were school closed downs during the COVID pandemic. And in Ghana, it was the same. Schools were closed for a year. And when schools reopened, a survey that was conducted by the Ghana Institute for Educational Planning and Administration noticed that there were high rates of school dropouts, both among girls and boys, and also high rates of repetition. And this, they compared within the populations of private and public schools, and that is the yellow-coded urban and rural schools, which is the red-coded, and then the wealth quintiles. And we notice, rather interestingly, the boys is the round, the circle, and then the diamond is for the girls. Interestingly, we see that dropout rates have been higher, of course, in the marginalized group, but also among boys. And as we wrap up, we want to look at some of the adaptations, and Ghana has been very good with having policies upon policies upon policies on climate change adaptation and the priorities. But what is important to mention is the fact that if we want to ensure food security, bridge the inequality gaps, then we have to also focus on nutrition-smart agriculture, nutrition-sensitive agriculture, because we talked about it yesterday in terms of dwindling nutritional value of foods, and we want to look at the soil fertility and all that. However, let me conclude with talking about the COVID response. And there was 230 million popped into the COVID response, out of which 50% went into economic relief and support to households. And that was quite intriguing for me, because we would have expected more to go into healthcare. So whilst we try to recover from COVID and looking forward to what adaptations within the climate change terrain, there has been suggestions to increase the budgetary allocation to healthcare. The Abuja Declaration in 2001, there was supposed to be 15% committed by governments to healthcare. But we find that in Ghana it's 3%. In Benin, for example, it's 2%. Nigeria is also 3%, Burkina 3%. And its healthcare expenditure into healthcare by governments is really very low. And so what we want to do as we get prepared for the next pandemic is that for low and middle income countries, including Ghana, livelihoods will be the biggest issue and not the effects of the next pandemic. Livelihoods will be greatly affected, and food security, malnutrition will be the one killing people and not the pandemic itself, or in complementary to the pandemic. And that is why improving on livelihoods, improving on healthcare, and taking very bold and pragmatic steps is very crucial. For instance, I mentioned this as the last point, that there was 2 cases of the COVID reported in the airport, and then the whole nation was locked down. And epidemiologists made the argument that no, in rural communities, for example, where we have found zero prevalence over many months, why lock them down? People were starving and going hungry when COVID was nowhere near them. So we have to have tailored, context-specific solutions to our problems, and that includes also for climate issues. Thank you for your attention. I want to say thank you to all those who have supported us during the period. Thank you very much.
It's about zoonotic surveillance and so about genomic surveillance. It's about surveillance capacity, which we need to improve to be able to detect things earlier so that we not respond too late as we've done for this pandemic. That's one. Number two, we had trouble with our data. I remember in the early months, I was invited to a Zoom meeting with 7 ministers, and they asked me, should we lock down the capital or not? Should we lock down Jakarta or not? And that's very difficult to advise because they wanted some projections, but we have hardly any data to be able to make credible modeling predictions. And so that makes things very difficult to make decisions. And that went on for quite a while until we start improving on the quality of our data and the scope of data and also the data capacity. But that's something which we need to work on for the next pandemic, because without this data, we will not be able to make good decisions, be able to control the pandemic. That's two. Third one, I think it's brought by many countries also, this issue of pseudo-academization and conspiracy theories. We saw a lot of misinformation and disinformations in the social media, and it makes it very difficult for authorities to be able to implement any public health interventions. And it seems like it's just going to get worse in the next pandemic. And but so many people going through infodemic, but I think underneath that infodemic, it's more an issue of trust pandemic. Since people, some people already choose whom they trust, so it's very difficult to change. There's an issue of building trust in the community, and it reflects that in some parts of the country and maybe other countries as well, there are problems of trust between communities and authorities. That's something which we need to work on for the coming pandemic and to be able to prepare better. So that's the third one. And then the next one is about equity. So we also have a huge problem with equity because we have a wide inequity in Asia, be it in terms of social, economic, or geographic. So in terms of socio-economic, this was very much visible because our workforce, 70% in the informal sector, meaning that they don't live on a monthly salary, they live from day to day, making a living day to day. So they're out in the street, they're selling things, and you don't expect them to be able to survive long if you tell them to stay home for more than a few days. But it went on for weeks and months, and it's very difficult to expect them to comply to many of the public health instructions because of that. So that's also a big homework for us. If we want to be better prepared, then we need to really seriously address these equity issues so that things could be better next time. And then we have an issue also in terms of health service capacity. So during the surge, especially the Delta surge, we were struggling. So a lot of the patients were outside the hospital even being treated, and that exposed actually the limitation constraints for health services. We already have human resource problems for many decades, and it just got worse during the COVID-19 pandemic, exposed the fragility and vulnerability of our existing healthcare system. It shows that our infrastructure is still inadequate to deal with the rise of COVID-19 cases. So that's something we also need to work on to improve our health system, health services, in particular the human resource. And then last, we have an issue in terms of the access to countermeasures. So for example, here you see a picture. This was a long queue of oxygen. So we had a shortage of oxygen supplies during the Delta surge, but there was also shortage in the beginning, shortage of masks, shortage of drugs, and also in terms of vaccines, it was very difficult to be able to get a high coverage in Indonesia within a short time. It took us a while, and in the beginning we relied on the Chinese vaccines, Sinovac, for example, because it's very difficult to get Moderna, AstraZeneca, or Pfizer, because this has already been bought by the high-income countries. So that makes it very difficult because we rely so much on terms of logistic, medical supplies, vaccine, drugs from outside, from other countries. And that speaks to the issue of vaccine equity, for example, and this is a global issue, I think. So if you see up to now, in high-income countries, coverage of vaccination is more or less 75% or higher, while in low-income countries it's less than 20%, so that's where we are at the moment. So that's another big issue which we have to address in terms of how to ensure equitable, fair access to vaccines and other countermeasures. So if I sum it up, I think these are the 6 key issues which we derive from the reflection from Indonesia. So first of all, how can we advance a warning system so that we can detect things early on and also respond early on, and then how we can better drive some other decisions, because that was a big issue. We didn't have much data to rely on to make decisions, so it becomes much more political than technical. And then also very important is how to enhance communication and trust, because that leads to the problem of disinformation, misinformation, and so forth. And then the equity issue, which is also making it difficult for us to implement large public health measures, and the healthcare capacity, especially in human resources, and then in terms of ensuring access to vaccine, medicine, and other commodities. And so if we look at this, many of this needs to be sorted out, not just at the local level, but also at the country, but also at the global level. And as we all know, there's a lot of discussions around this. Just recently, last month, WHO, the World Health Assembly, they had this 10 proposals to strengthen global health architecture, but it's not a consultation. And they basically propose 3 areas: governance systems and financing. And this has been translated to 10 proposals. And at the moment, this year, Indonesia is holding the G20 presidency. Germany is holding the G7. Indonesia is holding the G20. And within our Indonesian G20 presidency, we are advancing some parts of the WHO proposals, mainly about the financing, and then also about the countermeasures and access to countermeasures, distribution of countermeasures, and also about research and development and manufacturing hubs in below middle-income countries. So those are some of the things which are now being discussed, and we're trying to advance to the G20, which is not easy. This is just a snapshot of the picture just a few days ago in the latest G20 meetings which we hosted in Jogja. We hosted Dr. Tedros, the VP of WHO, and I wish I can report much progress, but unfortunately it's quite tricky and challenging because of the context of the crisis in Ukraine and Russia, which makes making agreements with emerging countries is also very difficult. But we are still making our efforts. Hopefully in the coming months, let's see where we are in terms of advancing these proposals to strengthen the health system for better preparedness and response. Thank you very much.
Thank you so much, Jordi. Thank you also for a very efficient presentation, which gives room for 1 or 2 questions now. And the rest we'll have for the panel. So, anyone that like to ask Jordi now? Rainer? I don't have this fantastic gadget that you played with yesterday.
Jordi, so nice to see you, if remote.
I cannot see you. I cannot see you.
Well, I will make myself visible. Look, Jordi, by the way, was a Humboldt Fellow about 4 years old, maybe. At the Institute, so Jordi is very well. Do you see me now? Oh, yeah.
Yes, I can see you now. Good to see you. Happy birthday,
Thank you. So you're doing a great job, and my question was, is there any attempt to produce the BioNTech Pfizer vaccine in Indonesia? And if not, what are the barriers to produce the vaccine in the global south? So wir zusammengebrochen. Kein Strom.
That was too hot a question.
With friends like this, who needs enemies?
Right, I can hear you.
I can hear you. You're back. You were somehow eclipsed. But now you're back in full strength.
Okay, good. So we've been producing vaccines in Indonesia already in the pandemic. So we have the capacity to produce vaccines in Indonesia. And but not for COVID, of course. And so, but we've already made deals with several companies to be able to produce vaccines in Indonesia. And unfortunately, not the BioNTech one, the one which is not under negotiation. I think it's Moderna. That's going to be under negotiation for us to be able to produce vaccines with Moderna. So we do have the capacity. We have been appointed as a WHO regional vaccine manufacturing spokesperson for Indonesia. I think there are several other countries of Africa, for example, the same in India also have the capacity. So we are building, that's part of the things we are proposing, to build regional manufacturing hubs, including in Indonesia.
Wonderful. AstraZeneca? No? AstraZeneca seems to be easier. No?
The one that is already in practice, Baylor College Medicines, so that one. And then Moderna is coming up, and I don't know the rest. Those are the two which is already there.
Thank you. I wish you well for the G20 summit.
Absolutely, we all do. We all do, and I hope, Rainer, that this issue of technology transfer is going to be discussed at some stage. Because it's not only to transfer technology, it's also to make sure that the production and the produced vaccines are being used. There are examples from Africa which tells us that we need to think through very carefully how this is being done with global solidarity. Thank you very much, Jodi. Have a good rest of the day or evening. What time is it in Indonesia now?
It's 2:30. I'm still in the office.
Okay. Thanks a lot.
Thank you.
Thank you.
Good morning. Clearly, the pandemic has brought in many learnings, and we have heard some from Indonesia. I have altered my topic slightly to again move to learnings rather than the actual experience of the COVID pandemic as it evolved. But certainly learnings come not only from the Indian experience, but in the pandemic from global learnings, which in turn have influenced the Indian response. To give a broad overview, in terms of the timelines, the virus entered late January 2020 through Indian students studying in Wuhan who had returned to Kerala. Then subsequently, in February-March 2020, we had Italian travelers going through North India as tourists, and also some religious gatherings in March, but they still remain as small clusters. However, triggered by the global panic and the experience in Europe and parts of North America, the national government decided to go into a nationwide lockdown, which started in the last week of March and went on until the first week of June. And this was perhaps the longest lockdown nationwide. And then we also saw that after the lockdown ended, the actual first wave began, which peaked in mid-September 2020. The second wave was principally driven by Delta, and India experienced its havoc in March and July 2022. The third wave came in January 22, mostly driven by Omicron V2, and the fourth wave is now rising in June 2022 in terms of case numbers, mostly through a mix of Omicron sublineages. In terms of the first wave, it was predominantly confined to urban India. The lockdown did not prevent, but delayed the wave, but enabled the health and social systems to prepare themselves. It declined by early January 2021, by which time Alpha entered India. But the wave which followed later on was less driven by Alpha, though it did happen in some North Indian states. But the countrywide huge wave was driven by Delta, which was first identified in India. While we may discount the case numbers or even the death numbers because of undercounting, and certainly there has been some undercounting, it is clear that the second wave was far more destructive than the first wave. And this actually coincided with a period of great laxity following the nationwide lockdown, with a huge number of super spreader events happening, religious, sports events, elections, the local bodies, state assemblies, and all of that gave a free highway to the virus and its variants to travel without any resistance. The second wave, which was driven mainly by Delta, now covered the entire country, urban as well as rural areas, because there was no impediment to enter the rural areas. And there were partial lockdowns, but no national lockdown, and there have been devastating effects in terms of deaths, overwhelmed hospitals, queues at the crematoria, and oxygen shortages, all of which have been reported in international media. The third wave, which came in January 22, was mainly driven by Omicron B2, which was less severe. By this time, we had hybrid immunity from extensive ineffective exposure to a large segment of the population, plus an accelerated vaccination program, which was now really ramping up. And also, it is possible that the Omicron, as has been reported globally, is also a less virulent variant with less degree of penetration into the lungs and blood vessels. But the systems too are much better prepared now, having learned the lessons from the Delta disaster. In terms of the fourth wave, it's been driven by a mix of Omicron lineages, and it's currently evolving in June 22 with large numbers of case counts rising and test positivity rates rising. But the hospitals are not getting crowded, there are no reports of serious number of deaths, and therefore it appears to be a relatively milder experience as far as the country's health system is concerned. And it's still, at the moment, mostly in the metros and in states with high mobility. We do not know whether it's going to be reaching the rural areas as well. But there are several learnings that we have. That is, firstly, in terms of tests, that this patented belief that tests are either totally positive or totally negative with 100% certainty has driven both the policymakers as well as the clinicians. And the recognition that tests can be false negative, particularly with rapid antigen tests, and can be false positives with remnants of nucleic acid, particularly the so-called dead viruses, that came in much later. And there has been a non-Bayesian approach, taking mainly the test results into consideration, not taking the clinical profile and the contact history to estimate the prior probability and then identify what the case management should be. And we also know that asymptomatic and minimally symptomatic persons did not get tested. And therefore, there were a large number of people who were not really counted as infected, even though they were, but they were uncovered later on in population-based serial antibody testing. And these serological surveys showed a 9 to 10-fold differential between virological tested cases and the actual antibody detected cases, which suggests that there has been a huge number of asymptomatic infections. The question, of course, is that R0 or RT, which are the basis for modeling and for tracking some of the rate of rise of infections, how accurate are they in these instances when a very large number of people are not even getting tested? In terms of transmission, the initial stance, like elsewhere in the world, was it's only droplets that matter. Aerosol was being talked about but dismissed, and we know that WHO recognized aerosol transmission only in the end of April 2021 and CDC in the first week of May 2021. But this also affected the Indian response to some extent. And masks, however, were introduced in 2020 in a piecemeal manner, learning from the East Asian and Southeast Asian experience, but became absolutely mandatory later on in 2021. Ventilation was not emphasized adequately initially, and travel bans were shown to be futile and counterproductive, both within the country and internationally. But there was a spate of super spreader events which was driven by commercial compulsions of industry wanting work to be resumed as fast as possible, politicians wanting the political activity to be resumed as fast as possible, and religious leaders and sports tournaments galore, all of these happening to be really laying the fast track for the virus to spread. But we do not know yet, from India at least, whether there is a recycling by infected animals. In terms of immunity, there was a hyped up notion of herd immunity, which was utterly misleading. Every 6 months, some politician or other would declare that India has attained herd immunity, and therefore people would completely relax and abandon COVID-appropriate behavior. And this was terribly misleading, and I can speak a little about herd immunity later on in the panel if you want me to. But hybrid immunity, which resulted from prolonged exposure to multiple viral waves of a large segment of the population, as well as an accelerated immunization program, appear to be quite protective in 2022. And we also now recognize from global experience as well as Indian experience that prior immunity, whether from vaccination or infection, protects against severe illness but not against infection per se. And that sterilizing immunity from mucosal vaccines is still awaited, but India is going the path of producing and testing mucosal vaccines. Whether there will be a pan-corona vaccine, we still have to wait and see. But now there is a big challenge to the number of boosters, given the fact that 4th dose, 5th dose are being recommended, whether there is actually going to be T-cell exhaustion of the immune system, which is going to be counterproductive both for virus variants as well as for other microbial infections. So how many boosters really are required and are useful needs to be debated. In terms of the health system response, there was initial preoccupation with tertiary care, with ventilators and ambulances and hospitals and intensive care dominating the thinking and the media. But the pivotal role of primary care was neglected, though that is the arena in which most of the prevention and early care and even continuity of care could have been ensured. Public health functionaries are rather limited in terms of numbers, and we had the strange situation of all contact tracing being undertaken in the initial waves by the police, not by trained public health personnel. And lack of reserve capacity, the lack of slack which is required, additional expansive capacity was severely felt. Of course, there have been infirmities in data and information systems which have been pointed out by global analysts. Private sector, on which many people depended upon, underperformed both in provision of timely, affordable care as well as in vaccination, because they really did not have much of a presence in smaller towns and in the rural areas. Community engagement and NGO partnership were badly delayed, and in terms of communication, there were contradictory messages on masks and gatherings, which gave the people the feeling that they could do away with masks, and then got infected, and gatherings were permitted, if not directly, were encouraged indirectly. There was inadequate explanation of the vaccines with incorrect explanation. Therefore, the moment we started seeing breakthrough infections, people's confidence in vaccines dropped because wrongful expectations that vaccines are going to completely stop transmission, that was the message incorrectly conveyed in the beginning. And of course, fake news has spread through all types of media. Risk communication was not customized to vulnerable groups, and that is a mistake. It was almost a common type of messaging which actually held sway. Most importantly, India, with its rich array of community-based organizations and NGOs, the community connect was not established. Neighborhood conversations, which are very useful in dispelling fake news as well as in building vaccine confidence, they were not encouraged till late. In terms of global solidarity versus nationalism, we have seen nationalism trumping global solidarity. Vaccine inequity has been spoken about. Even India, which is a vaccine production powerhouse, suffered because America invoked the Defense Production Act, and some of the raw materials and ancillaries that were required for our vaccine production did not come in till well into the Biden administration. And the global supply chains were badly disrupted, and therefore India adopted the slogan of self-reliance, saying that we will produce everything now in-house. We are not going to depend upon global supply chains. And the patent protection battle that WTO has waged, and right now there has been some concession of vaccines, but not on other medical technologies that are needed for pandemics. And this again is an unfortunate development that countries do not see the unified pandemic response as requiring sufficient relaxation of patent restrictions. And the variants of the payback, because if there are countries which are giving booster after booster but not supplying enough vaccines to the rest of the world, the variants that develop elsewhere in the world will find a way to sneak back into the countries which are vaccine rich. There have been gains in India, like in terms of increased investment in health. Now, learning from this, there is a great deal of attention being paid to enhancing the infrastructure, investment in vaccines, equipment, stronger surveillance systems, both in rural and urban areas, right from the village and block level. One Health is being prioritized, and we are likely to get the Southeast Asia region's One Health Center. And role of frontline health workers has been recognized recently with the WHO award. However, there is still reluctance to invest in adequate strength of the health workforce for a variety of reasons, which is unfortunate again. India has rightly emphasized digital health and health technologies as its growing strength. And there has been a strong impetus to telehealth, which was previously considered to be illegal by the Supreme Court of India, is now widely practiced after being permitted, because COVID has really brought about that change. And our vaccination program has been very efficiently aided by the IT technologies, and that is something that we can really feel proud about. And with a substantial degree of vaccination coverage of the adult population, upwards of full vaccination, upwards of 95%. And single dose vaccination upwards of 95%, and double dose vaccination upwards of 85%. But there have been losses in terms of negative social impact. There has been income loss. The poor have been particularly vulnerable. Schooling has been interrupted. Migrant workers have badly suffered. There has been gender violence documented, alcoholism, xenophobia, particularly against the northeastern states who have been mistaken in parts of India to be Chinese. And there has been no attention to ecological determinants for pandemic prevention. It's been mostly on technologies. The major learning for me is that an efficient, equitable, and empathetic health system is needed in the steady state, even without a pandemic or a public health emergency, in order to provide a swift, strong, and sustained surge response to capably counter any public health emergency. An inadequately resourced health system can't run fast on one leg to meet a public health emergency. Rainer asked me, and other speakers too, I think, with a couple of questions. And I have decided to ask a few questions of myself and the rest of the group. The first question is, can health and social systems prepare to meet future pandemics without lockdowns and social disruption? Can we be better prepared? Can we actually practice, if necessary, only partial restrictions in some parts of the country without having a national lockdown like India experienced? Second is, will national and global development pathways couple ecological sanctity with strengthening of public health systems? Are we going to be only focused on care and to some extent in terms of human prevention, but without taking into account the entire building up of ecological defenses against zoonotic transmissions, which are likely to see future pandemics? These are questions we must ponder over. Thank you.
Thank you so much, Rinat. There is time for a couple of questions before we move to the next presenter. Anyone? Where is this? Yeah.
Could you catch it and then throw it up? Thank you.
Bravo! Wonderful! 2 gold stars.
I'm learning.
3 people. Okay, please go ahead.
Yeah, thank you so much for the
And
introduction.
state your name, please.
Pasancha Haita from the Global Health Institute. I would like to ask, because India is a very diverse country, so if you know of any successful vaccination campaigns, and that was actually culturally appropriate or tailor-made for a specific group of people, or how did you move about this topic of diversity?
The vaccination program has been essentially driven by national policy and coordinated by the Union Health Ministry, but delivered with state-level health systems. So there had to be a considerable amount of engagement of the state level and even the district level with the authorities in order to drive it. One of the greatest strengths that India could fall back upon was the presence of community health workers, which was built in essentially for maternal and child health and immunization purposes. These are the so-called ASHAs, or the accredited social health activists. And also we have auxiliary nurse midwives who have been part of our healthcare system in primary healthcare for maternal and child health. They were all pressed into service. So states in which we had strong health systems and strong primary healthcare systems, and even some amount of good urban primary healthcare did very well even in the vaccination. Like for example, the city of Mumbai and Maharashtra, which had a good, strong urban healthcare system, did well. The states of Kerala and Tamil Nadu, which have had very strong health systems in primary healthcare and district level healthcare, they have done very well. Other states where the health systems were weak to begin with, again, they faltered because they did not have sufficient prior strength to build upon. So there have been regional variations, certainly.
Any other question? If not now, please reserve them to the panel.
Good morning and happy birthday to Hai and also Ryan. I'm also like Manuela, that I spent 21 years with Heidelberg since 2001. So today I will talk about the climate change, heat and energy, because Bangladesh, I think we don't need an introduction for Bangladesh as a climate change vulnerable country. Everybody knows that. And secondly, we always talk about flood. Last 30 years, my exposure to the northern countries, whenever I meet somebody, they say, oh, you're from Bangladesh, oh, you have flood. But I think we have started exporting flood to Europe and North America for the last 10, 15 years. And we are very resilient against flood. But heat is a real problem in Bangladesh. So this is the fatal feedback to my community. So I don't need to talk about the global level because yesterday many speakers spoke about that how the heat has been increased last several decades globally. I want to focus on the regional level. You can see that these are the 5 countries in South Asia, and the Dhaka one, you can see the changes in the red color. So in Dhaka last 20 years, the temperature has risen 3 degrees centigrade. And yesterday, you know that everybody was kind of really afraid that if there's another 1 degree centigrade increase in temperature, how catastrophic will be for the whole world. And the Dhaka is considered as a heat island, not only the 3 degrees centigrade, we also have high humidity, 80 to 90 degrees centigrade, which causes real problem. So I want to speak a little bit about heat and health, and there's very little literature is available. Like heat stroke, everybody knows. So, like all these pictures of this summer in India, in Bangladesh, and also even in Canada, that how the heat, the people, the citizens, they're suffering from the heat stroke. There are a lot of evidence of the kidney disease, for acute kidney failure to the chronic kidney failure in Bangladesh. Every year, 40,000 people die from chronic kidney disease, and there are 2 million patients that are currently having dialysis. So if you look at the last 15 years, but there's not much research on looking at direct impact of the heat on kidney disease, but there are few literature, but not much. There are also literature of the diabetes, particularly this one study at BMG, they have shown how 1 degree centigrade increases the glucose intolerance, but also incidence of diabetes. In Bangladesh, last 15 years, that recently we have done a national surveillance, we found that the diabetes prevalence, it has increased from 6% to 13% nationally, and for women it's 14%. And hypertension is also increased to 30%. So many ways the diabetes and the non-communicable disease are increasing in Bangladesh. But again, we have not done rigorous or robust studies to look at the impact. Mental health, so it's not only that there are literature shown that how the heat affects the mental health, but heat also affects the hospitalization of the kidney disease, the diabetic patients, and also the patients who suffer from mental illness. So the heat wave in Bangladesh is not unknown. That's I already spoke about that. I just came back from Bangladesh, but now we have a flood. But last week it was 37 degrees with 85% humidity. And you can see this, the Dhaka in the nighttime and daytime, the temperature, Dhaka is the only capital in the world where daytime population and nighttime population are same. Usually most of the capital, they are not, like there's a difference because people commute. In Dhaka, they don't commute. And the population density in Dhaka, 37,000 per square kilometer. If I compare it to Germany, it's 240. And in urban slum is 220,000 population per square kilometer. So you can see that how the experience of heat can intensify for the citizens who live in Dhaka. And this is like at the study, they look at the urbanization. If you look at the red is the building that the growing 1989, and then you see the green, the vegetation, the blue is water body. But then look at 2009 on the left, the picture, the red is the built, that is unplanned building everywhere, it's a concrete jungle, and how the water body and the vegetation have been significantly reduced. And it has a linear relationship with the temperature on the right side. You can green in the 1989 where the average temperature in Dhaka was 18 to 20 degree. Then you come to the 2009, which is like a 32 degree average. So you can see that how the relationship of the vegetation, the build-up, and the water body has direct link with the temperature increase. So the cooling is recently like one of, I think, my favorite research topic I'm doing. So we think about the cooling that whether it's active or passive cooling. Active cooling is an unsustainable solution because in Bangladesh there's a high increase of buying air condition, and you can see the picture on the left top. That's like this is a tin shaded house, but they have air condition, and everywhere they are conditioned because people have no option other than buying. Recently, we did a study on the extra energy use to the air condition use, and you can see that for every additional air conditioning in the household, temperature increased to 50% to 150%. So the buying AC is creating a vicious cycle because air condition, we know that energy, and it reduces, it increases the consumption, and it increases also the heat. The passive cooling is a cost-effective solution. We have done a study, the painting roof to make it cooler in urban slum. On the right side is the painted roof. And our study have mentioned we did a randomized control trial, and our pre-post intervention have shown that the bottom graph is the blue, the daytime, and the top is the red at nighttime. But you can show that in the midday, it reduces up to 3 degrees centigrade. So painting is a good option for reducing the temperature and the passive cooling. But if we want to be cool, what are the eco-friendly solutions? So, of course, that in micro level is the roof painting cross ventilation house, but there's a problem in Bangladesh because the painting which reduces the heat is not available. So we have to export from India, from Pune, it cost us 3 times. But I think last time when I had a conversation with Rainer, he suggested us to try to the white painting, and we're planning to do that in the next study. The cross ventilation, how can you do the cross ventilation where the 21 million people live in like 25 square kilometer area? So these are the options, but I'm just showing that how much struggling it will be for Bangladesh to do that. Then with the vegetation, this is like a nice, interesting, the small baby taxi, which is the vegetation, on the top of it, and there are lawful roof garden vegetation. At the left, I'm showing that the plan for Bangladesh government to have an urban design eco-friendly. Again, the country with the size of Wisconsin in the United States, 144,000 square kilometer with 170 million population, we have to be very realistic. At the macro level, we can do the energy mix. In Bangladesh, 63% of the energy comes from the gas. These are the 3 pictures of Bangladesh where government is trying to the alternate energy, the windmill, the solar panel, and the electric hydropower, but it's only 3.3%. But the government is setting up a nuclear plant in Rupur for managing the energy crisis. But we know that there's also a lot of controversy. There's a group in Bangladesh against the nuclear power. So this is very difficult for even as a country to step up and then reduces the heat problem. So the future research question is that can passive cooling and early warning reduce the effect of heat waves on the health and productivity of the health workers? A recent study that Duke University has done in Bangladesh, it has shown we lose 7 billion hours every year because of the heat. And also the health workers, they are not productive. So we need to do some research to see the impact of that, and the passive cooling can reduce energy consumption. Because we started with discussing that, I think there's a question from the audience that whether high-income countries should take some responsibility and subsidize for the crop insurance that Manuela was talking about. But as somebody from the low-income country, low-middle-income country, and this energy climate change is responsible as the most of the high-income countries, I like to kind of provoke you with a few questions to ponder, on my last slide. Requesting a rich person in the low-income country not to buy air condition, is it ethical? Because they can suffer from the kidney disease or other disease. Is sustainable energy a pragmatic and ethical solution for new, non-poor in low-middle-income country? Those who are gaining, becoming rich recently in last 10 years. And the final question is that is aspiration for a comfortable life unacceptable? So, thank you very much.
Thank you very much, everyone. My talk is about the climate impact on health, what adaptation needs in sub-Saharan Africa. So as you said, it's really broad, it's not only Burkina Faso. I don't have the pretension to speak and give solution for all sub-Saharan Africa, but I will give some guidance and take example from Burkina Faso. So this is the outline of my presentation. I will be going through this one. So to say the climate change is really a global problem that affects various geographical areas, and it's manifest mainly by drought, precipitation, flooding, locust invasion, increased temperature, the land size, the seaside, and it impacts several domains on human life, like natural resource availability, food security, human health, livestock survival, and so on. And it's estimated that we will have additional death of 250,000 of deaths per year from malnutrition, malaria, diarrhea, and other stress, heat stress. So as a result, you know that adapting to climate change mitigation and its impact need really a very good public health preparation, programming, and interventions. So this is the conceptual framework of the climate change in health, impact on health. I want you to concentrate on the left and right. In the middle, this is really clear. Most people before me talk about this one, the climate drivers, the increased temperature, precipitation, extreme precipitation, weather events, and sea level rise, and the exposure pathway. So I want you to concentrate on the left and right. To say that not everybody, not every community is hit at the same way by the climate impact. And there are key factors that influence positively or negatively the climate impact on health. And on the right side, these are factors that influence individuals. These are social determinants of health, such as age, sex, ethnicity, race, economic status, and others. We have behavioral choices. And on the left side, we have the vulnerability as the largest threat to the communities and also the world. So how does climate change affect health in sub-Saharan Africa? It was expected that the warning in sub-Saharan Africa will be more than the other places in the world. And many regions will suffer really from climate change impact due to reduced rainfall, as in sub-Saharan Africa, main agriculture are really depending on the rainfall. So the climate change has also a tendency to exacerbate the existing health disparities that usually see, and it will hurt existing pressure on health, and also it will also have impact on the socio-economic state that is already thriving in Africa. But to say, if you look at this map, on the right side, you will see that talking about sub-Saharan Africa also means that you have a different climate zone. You have the wet on the north and the horn of Africa, which is really the hot desert, and you have the semi-arid, that is the orange. You have the tropical in West and Central Africa, and when you are going down, you have the subtropical to temperate climate. So it means that you have different climates in sub-Saharan Africa, meaning that all the part will be heated differently. So how does the climate change affect health? There are already overstress on health in sub-Saharan Africa, and the climate change will be had it negatively on this stress that is already existing. And some existing health traits will intensify and new also will be added, like exacerbating malnutrition, poor air quality, polluting drinking water, altering the geographic range in infectious disease pathogen. So you have the mental health, the medical and physical health, and also the community health will be impacted. So coming now to the adaptation, we'll use this sequential framework that has 5 steps that will be the kind of guidance to the countries in sub-Saharan Africa to build the adaptation plan. The first is to identify the scope of climate impact. This is the first point to go. And secondly is to estimate or quantify the additional burden of health outcome associated with climate change. The third is to identify the more suitable health intervention or adaptation. And fourth is to develop a written adaptation plan. And last and not least is to evaluate the process. Here is an example of Burkina Faso. Burkina Faso, this is the goal from the step 4, which is really to have a plan, adaptation plan, national adaptation plan for climate change impact, with the main objective to reduce the vulnerability to the impact of climate change by developing capacity for adaptation and resilience. And this plan has 6 main areas that is going from agriculture, health, environment, animals, energy, and housing. So for agriculture, they are doing well to promote adapted agro-pastoral production practices and to improve soil fertilities. In health, mainly it's to improve the early warning and the response system and to develop the research on climate change. And there are also action on energy and housing that are directly impacting the health of population against the heat stress. So what adaptation strategy for Africa? The first point is at what level should we have this adaptation and the content of adaptation. At the individual level, we should have some adaptation activities and community level. And the content should be the preparedness first, going from anticipating and making provision. And the response. The response needs to be innovative, it needs to be robust, and it needs to be timely. And what is the role of the public health? It was said before me, and public health should be innovative and prepare enough to respond within a limited time frame. So public health should assess the vulnerability, should identify the most vulnerable population, and eliminate the health disparities within the community. And what is the role of the research? The research should actively be done in order to continue to refine approaches to tackling the general health the challenges of climate change and to discover new and emerging links between adverse weather events and health. So, since the climate change itself is a global phenomenon, this means that mere national adaptation is not enough to tackle its impacts. So adaptation and mitigation of climate change impact logically require integrating it into public health planning, programming, and intervention. And countries minimize therefore build climate resilience health system to protect health and avoid widening the health inequities. Most of the countries say that health is really a priority area for climate change impact. Nevertheless, in terms of putting funding on climate change, is really low. Less than 2% of multilateral climate finance goes to health projects. This is really, really low. And my question is to ask how we can efficiently build the community surveillance to tackle new and emerging climate change impact on health in sub-Saharan Africa. And the second one is beyond the international public discourse related to climate change impact on health, what could be the path to secure funding for adaptation to climate change impact in sub-Saharan Africa? Thank you.
Let's have the first question.
Okay. Hello, Antonella from Healthcare Without Harm. I just wanted to ask you, as you were talking about passive cooling and the adaptation plans and countries, I was thinking about how we build capacity, right? Because many countries have built the national adaptation plans for the health sector. I think we cannot say we have made a lot of progress there in the implementation and in getting the funding to actually make those a reality and having today stronger and more resilient healthcare systems. So I was thinking probably in your research and in your work, how do you see ourselves, or probably like which are the barriers today? Of course, the funding to make this happen. Like WHO and others launched during last COP, the last climate conference, an initiative that I just checked Bangladesh and Burkina Faso signed to have resilient, low-carbon healthcare systems. The initiative is being launched just on Monday, but still the funding is not there. So I was thinking in your work, where do you see the barriers? Like probably for us to work, to keep in mind, to actually make this a reality, because I think we all know that passive cooling is a lot more efficient everywhere, not only developing countries. But that's still not what happens, and thinking the same with the adaptation plans. Yeah.
Is this a question to everybody in the panel?
Could be.
Okay, who wants to start? Malavika? Please.
Actually, one of the major problems is, I think Bangladesh, the two problems. One is the heat is not a priority for the government. So it's the flood. So that's number one, the policy is not there to how to control heat. And number two is there is a lack of awareness, both at the population level and also at the health workers. So if you go to a facility, the simple things, reorganizing the furniture, you see that the furnitures are next to the window, which is closed. Or like, that the cross ventilation is not there. So it's one of the policies, and second is the lack. We are so much focused, the government is so much focused on the flood, but then also now that how to do the energy. So there's this nuclear power plant and the bridge and infrastructure. So there's no priority.
Thank you, Malavika. Srina?
I think the governments, at least in India, both at the central level and the state level, are still to pay adequate attention to this challenge. They're still looking at the balance between the energy requirements and reducing the emissions, particularly the carbon levels. Urban planning is going apace, but whether just like climate smart and climate resilient agriculture whether there will be increasing conversation on climate smart and climate resilient housing is something that is still to enter the broader discussion. But it needs to be done in terms of better adaptation. But traditionally, there have been many methods that have been used in rural India and interestingly in urban colonial India, which actually was supposed to be protective against summer heat. Some of those probably may need to be brought back into current urban architecture.
Yeah, I want to talk about the multi-sectorial collaboration, and we find that in Ghana, for example, the Ministry of Environment is playing some role somewhere, Ministry of Housing is also doing something somewhere, Health, Agri, they are all into climate, but they are not really speaking, and many policy documents, and each is taking a different dimension. So one of the key solutions is also to come together in terms of intersectorial collaboration. And then the second point is also to look at it from human behavior themselves. So we see flooding in Ghana recently, and many is also because of poor hygienic behaviors, dumping of refuse in gutters, and building in waterways in slummy areas. So really, if we want to discuss this climate agenda, then we also have to let people be climate sensitive in their behaviors.
Okay. So to add on what was said, I might say having national adaptation plan as a starting point is already good, meaning that at policy level the issue is really taken seriously. But the implementation is a different business. When you look at the example of Burkina Faso, for instance, their main priorities, they have 6 priorities areas, but if you look at it in between, there are priorities of priorities. So as Malebika said, heat stress is like the priority when you look at the priority area in Burkina Faso, but not really well addressed. It's the same thing like health. Where they are putting the more effort is on agriculture, or food security, because this is very, very sensitive. This is where they are putting effort. The others, they recognize that there are priorities, but they are not really putting effort in terms of implementation. This is where the collaboration comes. I think we have all a role to play in this business, to push the policymakers to really go to implementation. For us as the researchers, research is a priority as far as health impact is concerned for climate change, but they are not putting really effort on research. We are doing research. Currently, what we are experiencing in Nuna, in Burkina Faso, is the Kulu that Malebika you have shown in your presentation. We have a Kulu project where we think that the result of this research could be supportive to go to the government and to show them what we are doing and what is the impact, and stress them in their priorities, because their priority areas, they say heat stress is a priority. So we have a solution for you. How do you manage it? So we have all a role to play in, and I encourage all of them as to really push the agenda.
Thank you so much. Now, Jodi, would you like to comment? We know you're out there somewhere, and if you would like to, please indicate and unmute yourself. I know that there are several questions in the audience, and I've seen it, so I'll get back to you. But first, Jodi, do you want to make any comments? Over to you. Okay, I don't think we will repeat the question. The question was quite long. But then what we will do, and be ready, that we will let you in relation to the other questions. I have at least 2. We'll start with the one in the back.
Yes. Good morning. Thank you for the wonderful session. My question is in general to you. The concept of just transition with regards to climate change, I understand, is gaining a lot of traction. So with many global frameworks being formulated of late, how equitable and successful has the policy makers of climate change mitigation, especially in the area of energy and climate change adaptation, been in creating strategies that understand the challenges a developing country faces, and what is the way forward to improve the current scenario in building a more inclusive framework? Thank you.
Thank you so much for a very clear question and important. We'll start with you, Jodi. Please unmute yourself. Let me check. Did you understand the question?
Yes, I catch the questions.
So the floor is yours. Please respond.
Thank you. So I don't have much to say in Indonesia because I think in the previous speaker there's an issue of priority in Indonesia. So we've been trying to advocate for climate change as well, but our Minister of Health is still very much focused on this pandemic issue. And it's very explicit that they want to focus on this, and so the issue of climate change is pretty much sidelined at the moment, just from the health perspective, even though this will keep pushing forward. So that there's not much, unfortunately, that I could share from the Indonesian side on climate change because of that in the past couple of years or so. That's all.
Thank you, Jodi. So we'll go to the panel here, and we'll start with Ali.
Thank you for this question. I think to have a more comprehensive framework to address the climate change issue is really a good way to go. But you also know that if you look at the different priority areas, each area goes to different ministries. So it's like you have a broader umbrella, and in between, each part has to play some role. You don't have a Ministry of Climate Change, where you have everything going to one place. So you have to keep it, you can keep it comprehensive, but for the implementation, it has to go differently. What I would suggest, my recommendation is really to get the population to be involved, to be climate sensitive, to really be active, not be staying passive, so that we will be really able, together with the policymakers, to go to a clear implementation.
Yeah, and I want to talk about energy efficiency and some of the interventions that are currently ongoing in Ghana. The first is the free distribution of bulbs that are energy efficient to households. Second is that state institutions are given some quota of energy which reliably they should be able to use to sustain them over a period. When they overgo that quota, they have to pay for the energy that they consume. And in homes, we have now prepaid meters. It used to be postpaid where people could use and go overboard. So with the prepaid meters, people have now become a bit conscious because you keep buying at your own expense, and then it helps that people become a bit more conscious about the use of energy. And then I also talk about fuel for cooking. And many homes now are also trying to go into biogas to use for generation of gas for cooking rather than the conventional approach. And even with firewood and charcoal, there have been attempts now to use the wood fire from the water lake that is rather causing stampede and boat accidents. So rather than cutting the trees from the forest, why not use the ones within the water bodies, which are also very strong and they are good for energy cooking. But then let me wrap it up by saying also that in terms of the sectorial collaboration again, there have been also attempts to see across the West African sub-region how the governments can come together, because Ghana sells power across the board, how power can be sold and how the load can be shared in a way that energy efficiency is realized within the West African sub-region. So that's also some of the discussions that we have to progress on.
In terms of global energy equity, clearly the debate is whether developing countries who previously have not contributed substantially to emissions but are currently increasing their emission contributions should slow down because they're also aspiring for faster economic development. And they believe that countries which are now high income and which gain substantially from their profligacy of energy utilization in the past and high levels of emission are responsible for this. That debate can, will, and will go on. However, it is also important to recognize that the low and middle income countries are going to be, and are even now currently, the major victims of ongoing climate change. So we can't just keep on blaming and then be inactive as a result of that. And therefore, it is incumbent upon us as a global community to invest in changeover to renewable energy sources and have high-income countries contribute substantially to transfer of green technologies to low-income countries and middle-income countries so that our transition becomes faster, so that the whole world becomes safer. So I think the finger-pointing should stop. We must become a collective global community, recognize the errors of the past, and share the resources for the future.
So I think that I wish that the Bangladesh government could work like the Ghana, because energy efficiency bulbs are 3 times or 4 times more expensive in Bangladesh than normal bulb. And also, like, we don't have yet the high coverage of the prepaid meter. Still now it's postpaid meter. But we also have to be realistic that definitely, like I just want to give it like an example that in 90s when I started working for public health, that the child marriage was a problem, and then there was an idea that we'll go to the community and say that it's a right for girls to get married after 18. But the family doesn't care about the right. They're more worried about the security. So now, climate change is a really jargon to most low-income countries. Whatever that we are saying, that they don't understand because it does not affect their daily life. So that's why we need more research on the health implication that is much easier for them to understand. And you see that you have the dialysis patient, the diabetes, the mental health. So that's the one thing. And the second is that when we talk about that, of course, we should not blame the higher income country, but I'm saying that there are skeptics and they will be resistant. So we need to be prepared how to make, them calm down and then to be compliant with the climate issue, especially energy consumption. And so one of I would say the solution that we also just did the study that at the household level, we just told them that follow this thing, that have the air condition at 24, not at 18, turn off the light because the electricity bill will be lower. And we found that the high compliance. So we need to be very pragmatic because for a person in the rural village or in the urban slum, they are not into all this big talk. They are living their daily life. And we have to make our problem to be relate to their daily life. Only then they will comply with that. Otherwise, we'll have the seminar and conference and all these issues. The problem will not be said. Because we represent like 0.01% of the population. So we need to be really kind of respectful and I would say that sensitive about a person's need at the household and make our communication better, that showing that how the climate change, this type of behavior is affecting their life and their future life, their children or grandchildren. Thank you.
Before letting Rainer in, I hope the audience understands what a great panel this is. There is a lot of wisdom amongst these 4 people, plus Jodi at a distance. Your turn, Rainer.
I make myself visible to Jodi. Jodi, do you see me? Where's the camera?
Up there.
Okay, good. I want to make a comment and a question to all of you, and the comment goes back to a number that Michelle mentioned and others too, namely that by 1 degree warming there will be 10% less food production in countries, many countries in the global south.
Why not?
Yes? Wo soll ich denn hingucken?
Nein.
Dahin, okay. So many people think that it's the dryness that does it, and that's only the relationship between the weather, climate change, and the plants. That's wrong. It is also the flooding of the field. It's too much rain and too little rain, and the alternation thereof. And we showed this clearly with Ali in Burkina Faso. So my first question is, of course, Bangladesh is always flood prone, and you are very conversant with it, but in Ghana, in India, and in Burkina, does the government realize that it's not only dryness that causes the lower harvest? And second, it's not only between the sky and the plants, it goes through the human farmer. Heat reduces work capacity dramatically. And we are showing that this is as important as the direct effect of weather on the plant. And so this cooling, I come back to your cooling, Aditi is not in the room, right? And to the cooling, we have, in Burkina, we are testing cool roofs, a very high technology film on the tin roof, reduces the indoor temperature when they sleep by 2%. 2 degrees, sorry, 2 degrees. That is exactly what the climate increase will do. So we need to work on the human and on the plant. And smart agriculture is in everybody's mouth. So my question to you, are you aware of the important effect of flooding in addition to micro droughts? And second, are you aware, particularly in India where Torch Hellstrom worked, you may know him, and showed this effect, that the humans suffer from heat so that their work productivity goes down like this per degree. And what do we do about it?
Microphone? The microphone.
Okay, so Rainan, I actually shared a passive cooling in Bangladesh, but urbanization is a big problem. And yesterday, I think that was the discussion, Dean Michelle and Manuela and I were having that of this crop insurance, that how can we reduce the urbanization or the migration, even the cross-border migration from Mexico to the USA or from Khulna to Dhaka, because it's the economic reason, whether it's the high heat or the crops failure because of the river erosion or the flood. So if we want to reduce the urbanization, which is another reason for the heat, and then I do think that it's important that to think of the decentralization, to think about how can we help the poor people in terms of the agriculture, and with this type of information to the population about how it affects their daily life, even the food security. And last time I spoke that you talked the roof painting. It's a very easy solution, but we have to import it from the USA, from the India. And I have spoken to many, the painting company, they don't want to do that. They said that is there a market, people will buy. So we need to have I think Faith has spoken about that, and also Ali, that how can we make more collaboration and communication with the different stakeholders, because it's very silo-based intervention and silo-based policy. So making dialogue and bringing everybody on the same platform is very, very important.
Thank you, Raina. You posed two questions. Firstly, on the dual nature of water stress on reducing agricultural productivity. And the second is the impact of heat on human productivity. The first is very clear, that apart from droughts and limited water availability, which affects agriculture, the other type of water stress comes from flooding, especially unseasonal rains, which are now increasing and disturb the crop cycle. And also, for example, in coastal areas, where there is a lot of coastal flooding, and Sundarbans is an example of that, not only are crops destroyed, but the salinity of the water increases, and that also is detrimental to the crops. So we definitely do need to look at how we can adapt to this, both in terms of reducing the amount of coastal flooding, But that doesn't, of course, stop the unseasonal rains. But we ought to really come into much greater amount of climate resilient agriculture as well. And recognizing that staples and even fruit and vegetables are very, very susceptible to increasing heat, we ought to really look at millets, sorghum, chickpeas and others which are now being shown in different varieties to be much more climate resilient. And they are indeed even better for human health. Instead of consuming a huge amount of staples, carbohydrate rich, if you can actually get some of these protein rich and fiber rich crops, they may be better for human health in other ways as well. So we ought to really look at it. But of course, the question of guarding ourselves against the impact of the increased water and flooding is something that we need to really look at in terms of our planning, both for human safety as well as for agricultural protection. But I think climate resilient agriculture is one way to really invest in. The second is in terms of human productivity falling down quite a lot. That, of course, is going to be a very important feature in the future and is going to impact agriculture as well as other forms of work, particularly outdoor work. And we ought to really look at, of course, heat protection plans as much as possible, though in the open fields it's going to be more difficult, but even there we ought to be able to come up with some alternatives. India, for example, our own institutions have produced urban heat protection plans for the city of Ahmedabad, which have shown a substantial decrease in mortality in the years that followed, despite a larger increase in summer heat. And that has been adopted by the National Disaster Management Authority. But a lot more needs to be done in this area. And certainly human productivity needs to be also protected as much as possible. But then we must look also for possible technologies which reduce the amount of human labor that is required.
Thank you very much. I'll take it from the human labor because when we talk about productivity, still in developing countries there is whole and carcass farming, there is subsistence farming where the hectare per farmer is very small, and we still have a lot of women who do much of the labor work on the farms. That is the first point. And the farming is not mechanized. And again, the average age of the Ghanaian farmer, for example, is 55 years. What energy would such a person have to be able to cultivate enough to feed beyond their household, even feed their households? So making agriculture enticing, appealing for the youth is one of the key areas that the government needs to work on, and in fact attempts have been made at that. We have, for example, planting for youth and jobs. Intervention, but the approach has still not caught up with the youth yet, and youth find agriculture not appealing because we can't see that mechanization, that irrigation, having a technology that makes agriculture less labor intensive. We are not there yet. So that's one of the key issues that we need to consider for developing countries. Then I talk about flooding. We see flooding in the national capital, and because of that, it is high on the agenda of the government. When there's flooding in the rural areas, it's like nobody cares. And again, the flooding that comes from the spillage of the Bagri Dam in Burkina, it is year on year on year. People farm, then the dam is opened, and then their farmlands get flooded. The only thing the government will say is, move away, we are about opening the dam, move away. Year on year, people are just cautioned to move away. Move to where? Are they going to carry their farms on their heads? And that is what keeps happening. And then they spill the dam, they lose their crops, they come back to farm again. So we really need pragmatic solutions. People within that enclave, what do they do? What interventions would you provide for them? Would you alternative approaches? All those things are really nitty-gritties that affect the everyday person, which the government that does not think about. So that's and the last point I want to mention is the interest now in cash crops. So people want to grow cashew, cocoa, because they get immediate money from it. And in my village, for example, it is ginger. So you go to the village, there is ginger, you can get cassava and corn, because there's immediate money for the cash crops. So how do we market the other food crops. The farmer does not have any market for their food crops, but has market for the cash crops. So making the food crops also very marketable is also one of the ways that we encourage people to expand their farming.
Yeah, to just add on this one, I would say the first point of your question relative to flooding and the drought and the mini drought. This is really well taken by the government because they have projections. At the beginning of every rainy season, they make some prediction to the course of the rainy season and they plan for adaptation measures. Instead, when they are expecting less rain or too much rain, they observe the harvest will be damaged by the end of the harvest season. So they come to plan for this one. But yes, this is not really the end point because there should be something done about the flooding. For instance, for us they used to make dams to collect the extra water. But these dams are not really maintained. The maintenance is not done and they keep on doing new one while the old one are not working. So it seems that there is no consistency in the management of the flooding in the nation, really. And if you talk about the heat stress, this is really taken into account. If you look at the adaptation plan for Burkina Faso, there is housing condition where there are encouraging for new housing pattern that will decrease the temperature inside the house. But the way it's implemented is not really, the uptake is not there. So it's something that is in a plan, has started, but it's not really at scale. So there is something that needs to be done for that.
Thank you. Jodi, you want to come in briefly?
Yes, I think some of the previous speaker and a lot of the media gets more attention on this curriculum. That's why we are moving the curriculum as managed development curriculum. But there are, as my writing suggested, there has been a lot of reports also against flooding on crops, and so a lot of farmers are facing real extreme weather because we are not being flooded. And I guess attention because all of this extreme weather values and the impact on the food prices which are affecting these soils. So that's where I guess the attention will specifically when we actually see the impact on the food prices, which is not sorted. I'm not really knowledgeable about hard plans of the government at the moment. This is something we will wait to talk about. The question is whether or not they are aware of this issue. Yes, we are aware of the plan to have an impact on the process and also resist the process of the food. That's all.
Thank you, Jodi. You know, some time ago this morning, Rainer told me, don't prolong the panel. You don't need to do that if there is not enough discussion. And the situation is the reverse, which shows how good the presenters have been and that the audience is awake. We have one more question, and then I will take a question, and then we'll finish. Okay. So a brief question and brief answers. Do we have 2 more questions? 3 more questions? This is like an auction. 4. But let's see. Let's see.
Okay. I'll be brief. Hi,
Good.
I'm Trish Dana-Schvedler from the Heidelberg Institute of Global Health. I'm intrigued by, it's a question for Professor Reddy. I'm intrigued by your question, can health and social systems prepare to meet future pandemics without lockdowns and social disruption? I fear that now that we've done it once, governments are going to reach for that in the future, and I don't think the public health community has properly demonstrated the health impacts of lockdowns. It was said once that pandemics are a social phenomenon with a medical element, And part of the error was that we treated it like a medical problem and we only thought about health systems and we didn't think about health determining systems very much. So my question is, have you got any thoughts about what the alternatives might be besides what we already know, early warning, early response, and how do we stop policymakers reaching for this lockdown extreme measure in the future? Thanks.
We'll take one more question and then you will respond the way you wish. Peter?
Okay, thank you, Peter Berman. I wanted to just come back to the theme of health system response. The pandemic was an acute infectious disease crisis. Admittedly, it lasted longer than we thought it would, or it is lasting longer than we thought it would. And climate change is a long-term, chronic, systemic crisis. We can think about what healthcare delivery's role is in response to these crises. We've seen the issues around treatment of patients with COVID-19. We've heard about diseases that will be caused or exacerbated by the impacts of climate change. But what about public health systems? What's different about what we need to see public health systems do in response to these two different kinds of crises, and how well are they prepared? What do we need to do to prepare them better for this?
Thank you so much, and panel, you can choose which question you want to answer. Not everybody has to take both. Who wants to start? Ali, you have the microphone, so why don't you start?
Okay. I think your question was about how do we prevent from the many public health measures that we have seen during the pandemic. I think the public health should be well prepared. It should be well prepared to face the pandemic, because what happened was that like a general panic. Nobody knows where to go. So there was different measures coming. I think there should be a well preparation of the public health, well-trained people that are really doing the surveillance, and make some assumptions or some, I don't know if I would say some tests to prevent such a situation. It's not easy to do, because, but I think we have learned a lot with current pandemic. We have learned a lot. We have learned that we felt that we were solid, but we are not. So we have really to improve the way we are doing business in public health.
One of the reasons given by most governments, including the Indian government, for the lockdown was, okay, we knew that this would not prevent the pandemic from continuing. We did not expect the lockdown to terminate the pandemic, but we wanted more time to prepare our systems for response, because this is a new virus. We did not understand the transmission dynamics. We did not know what the clinical impact is going to be, and we did not know what kind of medical containment measures would be required, all that kind of thing. We have seen now in China repeatedly huge lockdowns being imposed, but without any measure of success being demonstrated. So I think the real answer is going to be to strengthen our health systems, particularly primary healthcare systems and the surveillance in the primary healthcare systems, so that we can have a good response. And of course, it has to be a connected primary healthcare system to other levels of care, so that people who really require hospitalized care can be taken care of. And also early adoption of preventive measures, like for example masks. We delayed masks too long. I mean, WHO went around saying test, test, test in March, February and March 2020. If they had said mask, 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 the things might have been different then. So I think we must learn a little more and be respectful of experiential wisdom, for example, which was there in East Asia, Southeast Asia, during the SARS pandemic, that masks worked. So we must actually plan much better, build our primary healthcare systems much better, connect different levels of healthcare much better, and if lockdowns are required in terms of cluster containment, when a new variant comes in and you want to study or if something else happens, then do it in a relatively confined space, not a nationwide lockdown or a statewide lockdown, urban and rural areas being treated similarly. I think we'll have to be much better strategists in the way we deal with future pandemics rather than a knee-jerk response.
Quickly cite the example of how the vaccination was rolled out in Ghana. Other than in the healthcare facilities, the community health nurses within the primary healthcare level use the approach of the child health campaign system. So they have them move from house to house to deliver the vaccine, of course, to those who accepted. And also the vaccine was available within the child health setting, such that when you take your child to the child health clinic or for antenatal care, you can also take the vaccine. So that robustness within the primary health system, where you have the healthcare accessible to the people already, is really one of the strongest starting points. The second quick point is improving on travel medicine. If the landholders were closed for over 2 years and it took a serum-prevalence study before the landholders were opened. Meanwhile, the airport was opened some few months later. But then we have to generate evidence. Without the evidence, how do you convince the government that this is the way to go? So for developing countries, generating quality data and making the government, who is a classical politician and has their political agenda, to understand the health issues and emerging issues is critical.
Thank you so much. Before closing this session, I'd like to remind all of us that the title of this session was Health System Response. I hope it's not only me that, as a take-home message, understood that this is way far beyond the health system. Quite a lot of the presentations focused on other sectors, apropos intersectoral action. Another take-home message is the lack of a global governance mechanism. And I hope, Rainer, that you're attentive, because these things need to be discussed during this session. Finally, I'd like to ask the panelists, you have a chance. You will meet, each and every one of you will meet your leader, be it the president, prime minister, whatever, in the elevator, and you have 2 sentences to clarify what needs to be done in your country for improving the health system's response. You start.
Okay, so we are the country with the policy. Okay, so the Prime Minister Hasina, we have universal health coverage, global health security, and health promotion, like 3 units. Just sit with all of them and prepare a plan for the health system response.
The first message would be ensure a primary healthcare-led universal health coverage system in which a continuity of care, connectivity of care is assured within primary healthcare settings, urban and rural. The second is health is the best summative indicator of success across all sustainable development goals. So focus on health as the principal measure of success in all development planning.
And knowing that health is wealth, the first key issue would be to increase budget funding for health. And the second is to make it enticing for people to work in rural areas. Provide incentives for those who agree to work in rural areas, so that can be a way to strengthen primary health care.
Health system has to be very strong. Being very strong meaning that the surveillance would go from the community to the headquarters at the Ministry of Health. And what is lacking in our health system is that it is not consistently linked to research. These are 2 different sides sitting in parallel, not communicated enough. And for the climate change impact, We need strong health system, we need strong research, and we should be linked.
Thank you so much. Join me in an applaud to this excellent
Let's start. So welcome back, and hope you had a refreshing break. Rainer. No, sorry. The session now is early warnings. So we have a lineup of really interesting talks on early warning systems and preparedness systems. We have a slight shift in the schedule because the second speaker couldn't join, he's sick. So instead we have a substitute. So Colin Carson couldn't join, and instead Marina Schwarzbach will present this study in place of Colin. So we'll still have it in our agenda, and that's the good point. There will be a panel discussion afterwards as well, and we'll have about 15 minutes for each presentation. The first speaker is Chris Ebbay, Professor Chris Ebbay, who most people know. She's been in the field of climate change and health forever, I think, since the field was started or incepted. And Chris is at the University of Washington in the US. She's been contributing to most IPCC assessments, I think, where there's been health covered, and she has been working globally on these issues for so many years. So, Chris, we look forward to hearing your talk.
Thank you very much. I appreciate the kind invitation. To give you a sense of how long I've been working on this, I worked with Joachim when he was a graduate student. I'm going to talk a little bit about early warning and response systems, highlighting a few of the issues I think were important going forward. I want to start with an event that happened a year ago in the Pacific Northwest in the US and in Canada. It was a heat dome that developed and sat over that region for about 3 to 4 days. The numbers are still coming in, but about 1,000 excess deaths. So nothing as dramatic as the 2003 heat waves in Europe, but still a significant number of excess deaths. Apologies that the numbers on the slide are in Fahrenheit. That's what we still use in the US. Although perhaps the UK may go back to that if Prime Minister there has his way. The event was unprecedented. Usually when you break temperature records, you break temperature records by tens of degrees. The region broke temperature records by 5 degrees Celsius. That had just not happened before. There is a statistical process called detection and attribution, the purpose of which is detection and attribution, where you detect whether there's been a change, in this case in the intensity of this heat wave, and then determine the extent to which climate change could have contributed to that heat wave. That analysis suggested, in fact, that this event was virtually impossible without climate change. So in essence, this, and there's been other heat waves, one in Scandinavia, one in Siberia, one in Japan in the last couple of years, that were also considered to be virtually impossible without climate change. We can say, because of these analyses, that people are dying from climate change. It's not that we have associations with weather patterns and we have projections for what could happen in the future. It's that climate change here and now is causing suffering and death. During this heat dome, we had a 69-fold increase in hospital-related presentations. For heat, the hospitals were pretty overwhelmed with COVID, and this was almost more than they could have managed. They did manage. They really worked hard, but it was a significant challenge. They had calls for the heat coming in every few minutes. There's all kinds of stories about the challenges that the emergency departments faced. It's not easy to cool people down when their core body temperature gets really high. And so the emergency departments, as people came in with these very high core body temperatures, put people into body bags and filled the body bags with ice. One of the emergency departments just about ran out of ice. I also want to make the important point of when we think about early warning and response systems, I'm going to focus on human health, but it's not just human health. It was during the height of our cherry picking season. Most of that crop was cooked, basically, because of the heat. We're one of 3 states in the United States that has regulation to protect outdoor workers. There was a lot that needed to be done to protect our outdoor workers. Our wheat crop also was affected. In the Sailor Sea between Seattle and Vancouver in British Columbia, there was low tide. The temperatures were so high that 1 million mussels, clams, and oysters were cooked. And that's food security and livelihoods for many coastal tribes. So we need to think about these extreme weather and climate events as all of society problems. Again, I'll emphasize health, but health is just a part of it. I mentioned detection and attribution. There was a study published last year looking across 43 countries and looking at the extent to which, over the last several decades, climate change was driving heat-related mortality. The conclusion was about 37% of heat-related mortality is due to climate change. But you can see the very large variability across the countries, and you can see the dearth of information from Africa, that the only data point from Africa was South Africa. We know that exposure is increasing to heat waves. These are data from the Lancet Countdown, published in the fall. Adults over the age of 65, children under the age of 1, and you can just see since 1980 this huge increase in exposure. You can see the numbers, 3.1 billion more person days of exposure for adults over the age of 65. Which is where we start talking about heat wave early warning and response systems. They have lots of benefits. And they're not, frankly, all that difficult. They are a significant organizational challenge. We did not have a heat wave early warning system in Seattle. There was a bit of one in Oregon. There were efforts in Vancouver. All 3 major cities did everything that they could to try to protect people. But standing these up at the last minute is really very complicated. You need to start in advance, and you need to have organizations at the table, and you need to think about what organizations you have at the table. I'll use as an example a heat wave plan for England. They've been doing this for quite a few years. And you start thinking about what's the purpose, what is it that you're going to achieve. Again, I mentioned health, but how are you going to interact with agriculture? How are you going to interact with people who try to protect outdoor workers? You think about what elements are necessary, and this is a particularly good plan in that it identifies a whole range of core elements. It's not just that the broadcast meteorologist stands up and tells me it's hot. I frankly didn't figure out that it's hot. You need to know what it is you're going to have to do to protect yourself. How are you going to communicate that? How are you going to educate the public in advance before there's a heat wave so everybody knows what to do? And you, of course, need to do monitoring, evaluation, and learning so that next year you can do it better. It's going to be difficult to read this. The point of this is that there's been a lot of effort to think about who's at the table. And thinking about who's at the table, of course there's health, of course there's the meteorological services. You need your emergency medical services, the police, the fire department, the ambulance services, who looks after elderly care facilities, who pays attention to what time kids go out and play in the playground to make sure that they're not out in excessive heat. We've got real problems in the U.S. with communities that are called redlined, and this is a process to exclude Black and brown citizens from being able to get mortgages. Those regions of the city have fewer trees. They're a lot hotter than surrounding regions. So you need to think about who's the trusted voices to reach out to those places. And thinking through all of the different kinds of people you want to have at the table so that you can have that coordination up front. A group that's traditionally been missing from these are pharmacists. I think it's really important to start thinking about having pharmacists. Pharmacists, at least in high-income countries, know every single prescription drug all of us take, and they have our name and they have our address. So there's possibilities to think about pharmacists as a way to get some information out. and to think about whether there's other kinds of activities that are traditional for particularly vulnerable groups, and if you can engage with those as well. And so you can't read this very well, but it's available in that plan to see how you go about identifying all these different groups, bring them together before the start of the summer season, and then make sure that you are all coordinated. Somebody will for sure have changed their cell phone number. There's lots that individuals can do in terms of protecting themselves during heat. These are 2 infographics put together by The Lancet for a series published in August of last year on heat and health. I encourage you to look at the graphics. The graphics are now translated into Spanish, into Hindi because of the major heat waves recently in Southeast Asia. They're being translated right now into French. And The Lancet is posting these once the translations are done, which I think is great. You'll immediately notice, looking at the kind of icons on the figure on the left, is that all of the strategies for keeping your core body temperature in a safe range during a heat wave don't involve air conditioning. That there's lots that people can do without access to air conditioning, and encouraging the use of these different kinds of approaches to keeping your core body temperature down can reduce the use of air conditioning, and if you have air conditioning, the risk that it's going to fail or brown out. I wanted to move on for a moment from thinking about those kinds of heat wave early warning response systems to some recent work out of British Columbia. There was an effort across the whole province to take a look at, in this case, extreme heat, developing indicators for exposure to the heat, to the sensitivity, what proportion of that community is over the age of 65, what proportion has chronic medical conditions, and the capacity of the communities to manage. The authors did this not just for heat, but they did this for flooding, for sea level rise, and for wildfires. In our region, if it's hot, we have wildfires. And the exposure to wildfire smoke has been really extensive. So understanding these different sources of risks, and then importantly, they put them together. And this kind of vulnerability mapping is a really important tool for decision makers. These are the places where it's urgent and immediate. And this is the kind of information that decision makers need, because they're not developing something for heat separate from something for wildfire, separate from something from flooding and sea level rise. It has to be done all at the same time. And so I think this is an important way to move forward in our community to provide policy-relevant information. Of course, the projections are that heat's going to rise. I include this study from the US, that the top row is with adaptation to climate change, the bottom row is without. Its projections for excess heat-related mortality towards the end of the century, under high emissions on the left, moderate emissions in the middle, and pretty aggressive emissions on the right. You can immediately see that in the map on the top right, aggressive emission reduction and with adaptation is going to be a much better world to live in than the bottom left. But even with both aggressive adaptation and aggressive mitigation, there will be excessive mortality and heat. It's a clear message for health system strengthening along with adaptation and mitigation. I know I'm coming up to my time. I wanted to make one or two more points. This is work that was done recently by Christopher Ostrom, looking at Sweden, particularly in Stockholm, looking at what needs to be done to maintain current levels of vulnerability in a changing climate. Almost all projections of heat-related mortality, like the one I just showed, say we'll make a range of assumptions and we'll tell you how many additional deaths there will be. Christopher asked a different question. He said, let's assume it's okay that the number of people who die in heat waves today is just fine. And given projections, how much do we have to reduce vulnerability by to maintain our current level of heat-related mortality? And the basic answer is, for adults over the age of 65, we're going to have to reduce current vulnerability by 75%. That is a massive reduction. And one way is heat wave early warning systems, and another is going to be changing our infrastructure, but even those may be insufficient. I already made the point that heat is an all-of-society problem, that we need to think broadly and collaborate across other sectors, so that when we develop our early warning systems, we address multiple risks that heat and other extreme weather and climate events are presenting to society. And finally, we're asked to put up research needs. This was accepted last week, and it's an outline of research needs for climate change and health. Throw this into the discussion later. And with that, thank you very much.
Thank you, Chris. Do we have one or two questions? Alina?
But you can't hear it online. Can you throw it further, Doreen?
Yeah, teamwork. Nice.
Let me get better.
Yeah, thank you very much for the wonderful presentation. So one question from my side would be, how do you think the literature is about evaluation of the effects of heat warning systems? Because my impression is that there are some smaller studies trying to evaluate the actual reduction of mortality or morbidity, but still I feel that there's not so much literature, and I do see that there are some methodological issues which make it difficult to evaluate heat health action plans. Maybe you could comment on that.
Yes, thank you. That's a really excellent question and excellent point. To date, almost no heat wave early warning system was established so that it was established with monitoring in mind. And it wasn't established with understanding what elements of the system are the most important. High-income countries can frankly do a lot more than many low-income countries, but it doesn't mean we're doing more and we're more effective. What is it about the heat wave early warning system that is the most effective? And making sure that we understand the elements. We're guessing of what elements we think are effective, but we haven't had that evaluation. And you're right, there have been some evaluations. They are pretty small, and they do have some pretty serious methods challenges with them. And so working with partners when heat wave or any kind of early warning system is established to make sure that we have that explicit evaluation component built in from the beginning.
Do we have another question? One more? Okay, cool.
Chris, thank you for that lovely presentation. I'm really stunned by the excess deaths of thousands. And I wondered, could you speak a little bit to what were the demographic characteristics? Did the data allow for looking at community-specific, race, ethnicity-specific rates of excess deaths?
Thank you. It's another great question, and it reminds me I should have said almost every death in a heat wave is preventable. Nobody needs to die in a heat wave. And the question I've posed to many journalists over the last year is, why don't we call these mass mortality events? If you had 1,000 people die in 3 days in not a very large region from anything else, it would be a mass mortality event. It's difficult because what we know about mortality comes afterwards. That in order to say somebody died from the heat during the event, basically it's people dying of heat stroke, and that's a very small proportion of the deaths. So what happens is afterwards there are analyses of what's the baseline number of deaths during that period and how many occurred. And when you look at these excess number of deaths, about half of them are for cardiovascular causes. And so that goes back to people who've got underlying medical conditions. We know that racism is associated with increased rates of cardiovascular disease, as is redlining. And so you can work backwards and say that these are the kinds of groups that are at higher risk. We know there's much higher mortality in adults over the age of 65, although in some countries it's only adults over the age of 75. With children, sadly, a lot of that are children that are left in cars unattended because parents don't understand how quickly cars heat up. They're not trying to do this, they're real tragedies. There is increases in people who take certain medications, like beta blockers, psychotropic drugs, because they inhibit the ability of your body to sweat. So in fact, the list of people who are vulnerable is really quite large. And it is focusing on, in particular communities, where you see that you can have higher rates of cardiovascular deaths, people who will die of a heart attack who wouldn't otherwise.
So like Nestler Way versus Madison Park.
Yes, absolutely. And there are efforts in the US under NOAA, the National Oceanographic and Atmospheric Administration, doing citizen science that are now mapping cities to see what parts of those cities are hotter. And that's really important. And our mayor and our administrator for King County is going to use that in the early warning system that they're working on. And this is why you need everybody at the table, because you need to make sure that all the voices are represented who can bring that information forward of just not who's most at risk, but what is it that we can do that can really make a difference. Thank you.
Okay, thank you, Joachim, for the introduction. And I'm actually glad that I have a chance to present this paper by Colin Carlson from Georgetown University. So just prior my presentation, I would say that the team actually spent several years developing the idea, and then they submitted their work, finished their work, and submitted their work before COVID pandemic struck. So it took also around 2 years for review, and so the paper actually comes out. But that's interesting how they were a little bit ahead of time, ahead of this global pandemic. So yeah, the paper is climate change increases cross-species viral transmission risk, and to put this work into context, into perspective a bit of our conference here, I would like to show you this overview a little bit and show that climate, nature, and animal ecology, vector ecology, and human ecology are a very complex and intricate system. So, and some studies or research efforts, they focus on one particular sector, or whether it's local dynamics, for example, COVID, whether it's for example, diseases which are transmitted by vectors and how they're influenced by climate change, or they look in global dynamics, how, for example, migration of people influence the spread of viruses. And this particular work goes into this sector, where we know that just a little part of the viruses that exist on Earth become zoonotic and become pathogenic for human beings. And most of the viruses, they silently circulate among the wildlife. So, and climate change and land use, any anthropogenic influence on the nature and disruption of ecology, creates new opportunities for, so to say, for viral transmission among the animals and wildlife, by then also creating an opportunity further or mechanistic link for a spillover to the human population. And it's very important to look into this sector, into this particular problem, because it creates an opportunity for an upstream prevention. So where we can, as human society, can look into and try to prevent the spillover and occurrence of or emergence of the zoonotic disease before it actually outbreaks and creates a local or even global pandemic. So a little bit on summary, I will go into science now. So they hypothesize that environmental change alters mammalian communities and exposes hosts, mammalian hosts, into novel viruses and actually alters the whole mammalian environment. They used an advanced modeling techniques, a combination of models. They used open source data, an enormous amount of data, and they basically also show where they approximate where hotspots of new viral transmission can be in the future. They projected till 2070 and basically showed where the new hotspots can be for zoonotic reservoirs. A little bit on background. So what we
what we know or what we think of the cross-species transmission, it's when viruses can transmit between different species, and it depends on opportunity and compatibility, and both are very hard to predict. So opportunity comes from ecological or geographical overlap of the host. So basically a physical opportunity to virus to get from one host to another one. It would be modeled as an encounter. Basically potential interaction between two organisms, either direct interaction or indirect interaction through a vector. And compatibility. So we know that virus can enter the body only if your immune system is compatible with this virus. And this compatibility is very well approximated by phylogenetical similarities between species. So this is basically a theoretical background of this work. Yes, and they look into the climate change scenarios, land use scenarios, and looked at how these scenarios can change the opportunities for novel viral transmission between different species. So a little bit about the methods. I said that a lot of models were applied, and for the modeling community here, so they applied species distribution model for around 4,000 mammalian species. So they concentrated only on mammalians. And they projected the climate change and land use till 2070. So they used RCP scenarios and shared socio-economic pathway to approximate how climate and land will change. Then also they used another thing like called viral sharing modeling, a statistical model based on phylogenetic similarities between species to model the probability. So how likely is that the virus will go to another host based on similarities, phylogenetical similarities between two organisms. So by that, they basically calculated a probable number of encounters between two species and the probability of sharing. So by the end of the day, they would approximate the probability of a viral jump between two different species. So just a little bit on nice pictures, we can see here that the probability increases with phylogenetical similarity and geographical overlap, a probability of viral sharing. Also, we looked a little bit into the how it can be done, how it can influence the human population by also projecting the density and human population using the data of socioeconomic data and application center, which were projected till 2070, and they basically overlapped the density population, human population, with their calculations of where the viral sharing can occur. Data sources, multiple data sources, they were used, and they actually took advantage of open sources. So it was mammalian virus data, biodiversity data, phylogenetic data, climate change and land use data, so scenarios modeling, as you know, and some additional data coming from habitat description of particular species. So results of this work show that the vast majority of mammalian species will overlap with at least one unfamiliar species somewhere in their potential future, regardless of the emission scenario. So it's already going on the way, and it will double the potential species contact compared to the present day. So the first encounters will be mostly concentrated in tropical Africa and Southeast Asia due to biodiversity in these regions. And that they approximate that all of it will drive novel cross-species transmission of the viruses about 4,000 times. So it's just also a picture. Here we can see they presented potential first encounters between species. The darker the area, the more potential first encounters will occur between the wildlife species. And you see here Africa and Southeast Asia are quite dark. Also, based on the climate change scenario, even the good one scenario, optimistic scenario, we'll still see a lot of
viral sharing, but opportunities among species also around Africa and South Asia. The lighter the area, the more viral transmission can occur there. Also, they looked into what kind of species can actually be more contributing to this, and they point out that the bats can actually represent currently maybe an underestimated link between climate change and alteration of the mammalian virome, probably because of their flight capacities. Another output is the population density, human population density, and overlapping with the hotspots of novel virus sharing. And basically, they show that the more dense population, human population, will be in the area also of the novel virus cross-species transmission, and creating more opportunities for spillover. However, they do not look into it further. Interestingly, that they suggest that mitigation alone cannot reduce the likelihood of climate-driven viral sharing, just because of if we slow down, because it's already on the way, they say, and if we even slow down the warming, it will allow animals to adapt even, and also to shift their ranges, creating even more opportunities for the first encounters. So, but it's not like we do not have to do a mitigation, it's just to draw our attention for this particular sector, and they call for targeted surveillance of wildlife, of pairing, viral surveillance, and biodiversity surveillance, just to upstream prevent potential zoonotic spillovers diseases. Yeah. So about a little bit about limitations. So they were concentrated only on mammals. It's a lot of species, but it's only mammals. So they didn't look into amphibians, didn't look into the birds, they didn't look into the marine species. And birds can be really good indicator or transmitter, or possible also contributor into the viral sharing and potential zoonotic diseases, and can be also used for basically upstream targeted prevention methods. Another, it's important assumption that they assume that species change their range in the same pace as climate changes. It's a critical assumption here, because we know that depending on their abilities or adaptabilities, some species will likely not be able to adapt to climate change and can go extinct. And with this respect, we connect the dilution effect, meaning that less hosts are available for the virus if many species go extinct, by then even increasing an opportunity for either cross-species transmission or even to transmission to the human beings. So that will have to be taken into account. However, I think that this particular work creates great insight into the wildlife contribution into potential pandemic preparedness. And these authors, they create a framework that can be further used into further investigation, not only an explanatory, but also using it for predictive tools that can be used further in decision-making or decision support for the really upstream preventive measures for future pandemics. Thank you very much for your attention.
Thank you, Marina. Marina only had 30 minutes to prepare prior to his presentation, so that was great. Questions? One or two questions? Yeah, cool.
Thank you very much for the nice presentation, Sascha Knauf, Friedrich-Loeffler-Institut. You're presenting the spillovers in general as something that we want to avoid, and I fully agree with that. However, with spillovers, there might also be positive effects. I mean, the human genome is made out of 7% of viral coding. So the question is,
can we also measure these positive effects? For example, infections with low pathogenic coronaviruses that then have induced, for example, cross-reactivity or cross-immunity against highly pathogenic ones. So these positive effects, can we measure them as well and include them into these models?
So if I understand the question correctly, you mean, for example, like in COVID, that prevalence of Omicron prevents for example, occurrence more transmit or more hazardous virus, or am I misunderstanding?
The example is in Africa, we have some studies suggesting that there were already antibodies against COVID. We also, I think many of us have expected that Africa is hidden harder by the COVID pandemic. Of course, there are demographic differences compared to what we have in Europe, but it could also be that there was already a virus circulating that has induced antibodies that protect people from getting severely infected. And these kind of positive effects are largely missing in models. And the question is there a way to also include those positive effects?
Yeah, theoretically, there is opportunity with the modeling of immunity status of human population and its susceptibility to viral transmission. You can use a mathematical model for this, and you should. The problem is one needs to have a data to inform this model like that. This particular work does not combine it with any other possible dynamics in a human population. One can go and complicate the framework, modeling framework, with an addition of how potential, so one needs to also model spillover with the human population and how these dynamics can be then later on presented in this population. And this representation will depend on the natural course of this particular virus and also epidemiological situation of this population. And this particular one needs to have seroprevalence data or immunological data of this population, so we can approximate the susceptibility of this population.
I'm going to talk a little bit about some of the work I've been engaged and involved in around early warning preparedness systems. So this one works better? Yeah. Okay. And I think important when talking about infectious diseases, zoonosis or vector-borne diseases, whatever, there's this split in the community. Talking about climate change, we consider early warnings, we talk about early warning systems and climate early warning systems along the lines as Chris was presenting. In the pandemic community, in pandemic preparedness, and generally in zoonosis and infectious disease, it's more about preparedness and preparedness systems. And early warnings would be a natural component of preparedness systems. Thinking about the role of early warnings for infectious disease, we have different stages of infectious disease. That could be in the sort of human phase, where we have circulation among wildlife or maybe domesticated animals, and there's viral sharing, but it's no spillover, so there is no real impacts on humans. And then we have phase 2, where we have spillovers to humans and we have sporadic outbreaks. Some of them could be contained and controlled, some could maybe not. And if it can't be controlled, it would be a little bit like or very much like the COVID situation, where we have a pandemic that spreads globally. In these different phases, you could think about early warning systems or preparedness systems and monitoring that detect certain indicators and monitor certain indicators and make predictions of early warnings for early action or rapid action to contain or to prevent spillover or to try to cope with the consequences of a pathogen that's already spreading among the global population. Obviously, those impacts and the responses that you could put in place in these different phases would be very different, and they would be having very different effect as well. We've seen with COVID that it's quite difficult to contain spread. That's already more or less, global. Humans are moving very rapidly globally nowadays, and it's very challenging. Although if we would detect it at an earlier stage, we have a high potential to actually do contain the disease outbreaks. And that's when we move from secondary prevention, adaptation to a situation to actually trying to prevent the situation to occur. And it's important to realize that the different work in the policies we develop and the early warning models and the early warning indicators have different roles in the system. So if we do mitigation, for example, in terms of climate, according to some of the impact on viral spillover and deforestation and the early stage, phase 1, spillovers can probably be prevented. And if we have other type of systems that detect outbreaks in humans and spillovers from animals to humans, we could control it or contain it pretty early. And then there is a lot of work as well on predicting epidemics among humans, and I think that's where most research are nowadays. So we need to think about how we could get to an earlier stage and intervene in an earlier stage in these outbreak and zoonosis and pandemic situations. So that's just sort of contextual perspective on early warnings. Now I'm going to talk a little bit about the case study of Vibrio that we've been doing together with European Centre for Disease Control, and especially Jan Semenza, who's been working at the European Centre for Disease Control for many years. Vibrio is a bacteria that's spread through sea surface waters, usually in brackish environments, so estuaries or the Baltic Sea. This study was that I'm going to talk about is conducted in the Baltic Sea because it's a very suitable environment for the Vibrio bacteria. Vibrio species also contain cholera, but I'm not going to talk about Vibrio cholera. I'm going to talk about sort of non-cholera Vibrios. So there is a number of different species that all cause severe disease among humans. Depending on where you are and how you get infected, you get infected differently. So if in the US, the most common pathway of infection would be actually through seafood, so oysters, and so on. So certain times of the year, there's a risk of actually getting Vibrio infection through consumption of raw seafood. If you're in the Baltic, the pathway and transmission pathway would be through wound infections, and you would get necrotizing wound infections and quite often septicemia. It's not a huge disease burden in the Baltic because you need to really be exposed and you need also to have wound infections. But still, it's definitely an increasing incidence of these type of infections because they're very sensitive to climate. Going to the US, the disease burden is much larger just because the sort of food pathway is more potent. And in the Baltic, there is not much seafood production, but if there had been seafood production, it would have been a much bigger problem. Okay, so Vibrio cholera is basically present in a lot of places globally. It's in the waters, it thrives when the waters get warm. Beyond 16 degrees, it starts growing, and higher up, it is very suitable and conducive. And especially then when the salinity goes down, and the salinity is not so high, it's much more prevalent. And that's basically what the science is telling us. It's that salinity and temperatures above a range of 14 to 17 degrees. That's the biology tells us that these are conducive environments and conducive situations for Vibrio growth. And if we use this information and look at the trends, and in considering the warming of the sea surface temperatures measured by satellite images, remote sensing, we could see quite strong trends, especially in the Baltic, but also in the northeastern US. The suitability and the growth of bacteria is very much impacted from the warming. If we look at the epidemiological data, we can see similar trends. So this is data from Sweden. Sweden is I think the only country in Europe where Vibrio and Vibriosity is actually notifiable. So there is not a lot of data, but there is actually data in Sweden. We had the opportunity to actually analyze individual data from Sweden and linked these cases to exposures of the sea surface temperature for their corresponding location and time of infection. We also had salinity, and then we looked at the relationship. The mean age of people getting infected is 41 years, so it's not a very old population. The number of proportion of blood infection is about 50%, so it's very severe among people getting infected. And the peak, you see the peak in the red bar, it's year 2018. And 2018 was a very anomalous year in terms of heat. It was very high sea surface temperatures, very hot. We had a lot of problems with forest fires and heat waves for a long period. And this is actually quite well telling the story about Vibrio. It's super sensitive to warming, and it really thrives in those conditions. And that's why we had these peaks. We both had, in terms of geography, we both had an expansion northwards, and we had a prolonged season and many more cases. So the other graphic here shows sort of an exposure-response relationship between temperature, sea surface temperatures, and epidemiological cases, and the relative risk of those cases. And it basically confirms more or less what the biology would say, that around 14 to 70 degrees you see an increase in the growth of the bacteria. And this also confirms that we also can expect an increase in the number of cases at this level. Using this information, John and ECDC developed an early warning system, which is actually operational and running. And you could actually go into this if you Google this a little bit complicated web address here. You could look and try this early warning system out. Just checking so it's not mine. And it gives you both information about today and the forecast for the coming week using forecasts of sea surface temperature. So that's operational, and it can be used in terms of judging, especially maybe if you have immunocompromisation, or if you have wound infections, whether it would be a good idea to take swims certain days in certain places. I'm running out of time. I wanted to mention also that we've been working on West Nile virus, and there is actually a similar strong signal in terms of the West Nile virus outbreaks in Europe. If we look at the data from the reports in Europe in different locations, we could also see a strong signal the same year in 2018. West Nile depends on bird migration, so the virus is carried by birds usually, and then there is a bridge vector which transmits the virus from the birds to humans. And the transmission area, as far as we know, has been expanding over the last decade as well. And looking at those drivers, considering mosquito and birds and climate conditions and social conditions and so on, we can see again that climate is very important for the occurrence and the spatial range and variability between years in the West Nile virus outbreak regions. So it actually holds promise actually for early warnings that could serve as information for better surveillance and maybe early action in new areas where it's probably going to emerge in the future when it heats up even further. This is the trend as well of the Vibrio West Nile risk in Europe, different European regions over the last 70 years. It's clearly going up, and that's also kind of an early warning that we need to have more and better surveillance to cope with this. And exactly that's also what we are going to do in a new project, which was mentioned yesterday. It's a European project with 19 partners, 10 million euros, to build and strengthen the surveillance and early warning systems in Europe to these type of threats where we have zoonotic diseases, vector-borne diseases, and environmental influences on them. And that's going to include novel components of surveillance as well, because surveillance is obviously very important. And mosquito, for example, and tick surveillance is tedious. There's a lot of new and very powerful data sources coming into play here that could help early warnings, and that's a citizen science. There is a project called Mosquito Alert, which is part of our project as well. And there is citizen science among communities in Sweden and Germany as well in terms of ticks and sending images of ticks that can be used for mapping out and understanding risk. The Mosquito Alert team is also working on smart traps that you could put out in communities, which you don't need to monitor yourself, but actually there is image classification algorithms in these smart traps and acoustic classification algorithms that could differentiate one mosquito from another and actually do all the analysis, the counting for you. So you could have a much better opportunity to know what's actually going on in different localities at different times, not only using climate information, but also observing mosquito behaviors and abundance. I think that's all I wanted to say. And if there's one or two questions, I think we still have time for that.
Okay. So, sorry for the trouble. Sorry that I'm not able to be there. I guess I have one thing in common with the UBE. Your UNICEF, we both tried to test the stability of our lower extremities, and the test failed both. So that's why we have to bring each other from wheelchair to wheelchair, I guess. Sorry for that. I would have really liked very much to be here to be with you because the institute means a lot to me. It was the foundation of my career. I did my PhD there. Much of the research that led to my habilitation was done with the institute. I did my first clinical steps in the travel clinic in the institution, and so congratulations to the institute. Rainer, also to you for your birthday. That was recently, and also, of course, Jochen. Maybe he is online. So today I would like to talk about the surveillance outbreak response management and analysis system as an example for the topic of sustainable digital pandemic preparedness and response. So we often like to think that the trouble is that we don't have enough data, but in reality that's not most of the problem. I think much of it is that the data is abundant, but the response management is poor, because we collect data, but we don't use the same effort to also organize the management of the response. And this is exactly where SORMAS kicks in. It was developed together with Nigerian colleagues in the situation of the Ebola epidemic in West Africa. And here it became very clear that all those control measures need to be organized and coordinated in a professional manner in order to be successful. And that's how we developed a system that addresses the different measures and procedures. It starts with the detection through signals from the community, from the hospitals, or also from the population via hotlines, or also through screening methods, for example, at hospital, at the airport control offices. And those signals need then to be validated and investigated by laboratories, by epidemiologists and clinicians. They will then be interpreted together with the data, and based on that data, the measures will be implemented. The clinical measures and also the control measures, for example, contact tracing, that now everybody knows. So all those different people, all those different professions, and there are many more, they use SORMAS in their mobile devices, in their wireless connection. They have their individual interfaces, and their activity is collected, their data is collected in the system, and analyzed in the dashboard, and this data also feeds back directly in customized way to each of those individuals in the field. So this demands, of course, a lot of process ones, because it's not only about collecting data, it's about organizing activities. So here you see a simplified process model of the different steps. The bottom box is on contact tracing. If you zoom in here on the contact follow-up, you will see a more refined process model with all kinds of activities, procedures, logics built into the system that will guide the healthcare workers from the different professions to do their job and to make it as efficient as possible. Up to the point that they then use the mobile device in the field work, and they, for example, here visit a contact person and verify whether the person has elevated temperature or not. And that leads to a lot of very fruitful data. Here you see the data from Nigeria. You see cases and contacts. The red dots are the cases, and the connections between them. This is not modeling. This is not artificial modeling. This is real data collected from the patients and the contact persons. And of course, this is a very fruitful and valuable basis for modeling and for other analyses and investigation. So, besides the contact tracing, we have other procedures that are necessary to control epidemic. Preventive treatment, for example, vector control measures, veterinary health measures, vaccinations, environmental health sanitation. And of course, they come to interaction at different necessity depending on the different diseases. And SORMAS has disease-specific process models for those different diseases. Here are some examples that you see that for some diseases you need multiple procedures, for some you need others. So depending on the individual need, the respective process models are designed and taught. In the upper left corner, you will see emergent disease X. We developed that from the very beginning in order to be prepared for new diseases. And for that reason, SORMAS become also very useful during the big monkeypox outbreak in Nigeria, and now we receive a lot of attention because several papers have resulted from that and people are contacting us. But it was also the basis to respond to the COVID pandemic. Before WHO had declared the COVID situation to be a public health event of international concern, we already had a COVID-specific module programmed into the system and available for the colleagues in Ghana and Nigeria who were already using SORMAS. And before the first SORMAS cases arrived in Africa and those two countries, they could use SORMAS as a digital tool to process them. In addition to that, we also have clinical management activities. We have a module that we have developed for Lassa fever to follow up the prescriptions, the clinical process, and all those different activities for the management of Lassa fever cases in the hospitals. Of course, SORMAS is not the only digital tool in the world. There are many of them. A very recent review done very systematically extracted information from nearly 2,000 publications, and it had the result that in Africa alone 30 different digital tools are being used. And if you look into those tools, what their functionalities and procedures are, you can identify that 4 of those tools cover 14 of the 15 core functions that we analyze. You can see it here in this dendrogram. On the bottom, you see the different functions. On the X and Y axis, you see the different tools. And you can identify in the upper right corner those 4 tools that have most of the functions. If you zoom into those, you will see that those 4 tools, some of them may be known to you, for example, PHI2, they still differ quite a bit, because SORMAS was really designed as a process management tool and not only as a data collection and surveillance tool. And that really makes a difference. I don't want to go into the detail here, but you can see that SORMAS distinguishes itself from other tools because of the different mindset that we have. Here is an overview of all kinds of different functionalities. Of course, I don't have time to discuss them all. I just want to raise your attention on some of them, the diseases, the process model that I already mentioned, also the epidemic event assessment, which goes beyond just working on individual cases, the automated quarantine certificates, the digital symptom diary that allows patients to feed in data themselves, and also the vaccination module. We think that SORMAS shall be developed further in multiple aspects, especially One Health. We have 2 research projects on that topic currently. We also want to develop further SORMAS as a tool that works not only at the regional, intermediary, and national level, but also at the international level, allowing to collect and aggregate data from different countries. The vaccination module that is already in action and work in Afghanistan, funded by USCDC, will be expanded to also include vaccine vigilance assessment. And we would like to also work on antimicrobial resistance monitoring, molecular surveillance, and as the data becomes richer and richer, we will need predictive analytics and epidemic intelligence to process all this rich information. The geographic spread has been very, very fast. We were quite surprised and maybe also a bit overwhelmed by the many requests we received from the many countries, especially during the pandemic. We have SORMAS in use in countries as different as Fiji, Nepal, Afghanistan, West Africa, but also Europe. And this is particularly interesting because most of those systems are used in countries that have little IT infrastructure. And in the highly industrialized countries, every country has its own system on this. And SORMAS is one of the few tools, if not the only one, that also is established in several countries in Europe at the same time. Now, this means a lot of work, a lot of people using SORMAS, a lot of people covered by SORMAS, and that also means we have reached the point that we cannot handle this as a research project anymore. We have many, many partners that have contributed to this development and that have made this possible. And so it's not possible to handle this as a limited research project with all the limitations. There is a very intense community of service providers, of funders, of researchers and users. So we now, just now, 2 weeks ago, we created the SORMAS Foundation, a non-profit foundation that will support this process and assure sustainability of SORMAS by curating the software, by offering consulting for the different ministries and health institutions, offering training for those who want to use SORMAS, for those who want to program in SORMAS, because it's an open source software, everybody can contribute software codes, for quality assurance and also for community building. So this has just been established. And the value proposition is that to support local, national, and international organizations in the development and implementation of SORMAS and other open source digital systems. That's important also. We don't limit our activity on SORMAS alone in the field of disease prevention and control. And with that, I would like to thank you for your attention, and of course, I'm ready to answer questions. But before I do that, I would like to share a little anecdote, as this is also an anniversary activity. And as the next speaker, Justus Spencer, is also talking on digital tools. Justus Spencer and I, we both worked jointly in the same room in the Heidelberg Health Institute. And at that time, we only had laptops or desktop computers that were not connected. It was not usual to have a connection. We wanted to have a network, but the IT department of the university was way too slow. Asked for ages, So we decided to develop our own IT network. We bought some cables, we bound the cable to a tennis ball, and we threw the ball through an opening of the suspended ceiling, and we were hoping that the cable would then end in the other hole of the other room. It didn't quite work, so I had to climb up the suspended ceiling, and I was climbing on the ceiling there to pull the cable to the next room, and then Mrs. Deutschmann, the secretary for many, many years in the institute, she was yelling at me because I was making too much noise. So I still have this trauma, Mrs. Deutschmann yelling at me. But we built the first connection, the first cable connection in the institute. Thank you very much.
Wonderful, thank you, Jarand. Questions? There is one question here from Rainer and from Tuan there. So, lots of questions, good.
Gerard, wonderful, and we talked about SORMAS before, but the main question, of course, to use this is the bandwidth and whether people do have, you must have a real smartphone to have all these functions. So if we look at Burkina Faso, to use this inside the HDSS or inside the country, is that possible with a relatively low coverage of smartphones that have all these sub-functions?
Yes, because it is not an internet-based system. It's the smartphone. It's a very simple smartphone actually. You don't need very sophisticated device. Works offline. You can do all the activities offline. That's also why we use dedicated smartphones, so we don't allow for people to download the system on their private smartphone for data protection purposes. But the cost of the smartphones nowadays is not a big issue. So you do need connectivity to synchronize, but you do not need the connection to work. So you can do all the work and you synchronize whenever you have a connection.
But who gets a who gets a smartphone? Then you need a new smartphone for every traced person, but not the population.
Right. Well, not a new one. You can also. I mean, already started. You need the dedicated smartphone. It doesn't have to be a very sophisticated one. But another aspect that connects to that is that we have invented a patent. We call it low bandwidth database synchronization. It's a technical procedure that allows database synchronization even in situations where you have very low bandwidth that is just good enough to send SMS. And so it's a system that works a little bit like the code repair in genetics that transmits the information, repairs the missing information, and synchronizes the databases even in situations where the bandwidth is very, very low and just sufficient to send SMS. So you don't send an SMS, but you use this SMS technology in the background to synchronize the databases.
Thank you. New question?
So thank you. Hi. So here Lucia Brunhara from IFA-Plan and also a doctoral student here at the Institute. By chance, I had a contact with a project in ECOWAS region that is supporting the implementation of SORMAS in Nigeria and in Ghana. I was quite impressed by the tool. As you said, there's other tools on the market. So now there's other solutions, IT solutions for similar features. So my first question would be, how compatible is SORMAS for use data from other systems? How do you make this link? Another question is that the other systems that are there, maybe they don't have so many features, but then therefore they are cheaper solutions. So how can you finance and how can you make the SORMAS sustainable, considering the limited funds that we have in the health system? And another thing, I understand that you have different features for different diseases. As you said, you made like a new one now for COVID, and Ghana and Nigeria could already start using it when COVID started on the countries. So there's also some kind of feature to identify new diseases or new outbreaks, things that we don't know that already exist and start popping up. So, thank you.
So yes, those are of course very nice questions. Thank you for those. So the topic of the interface, the interoperability is a very important one. And SORMAS is an open source system. So every other system has full access to the source code and can connect. We have built an interface linked with EHIS2 already, because EHIS2 is very widespread, especially in African countries. And also we have quite a number of quite sophisticated interfaces in the European setting with other digital systems in Europe. However, I must say, it's easier said to make an interface and to have it run than done, because different systems move at different speed, and you always need to refine and update again. So it's a problem, and if you can organize the health system in a way that you limit the number of different tools, the better will be your results. With respect to the cost, because the software is open source, so there is no license fees to use the software, everybody can contribute to the software. I think it will be sustainable because of that, because we see that, for example, with quite a lot of money in Europe, we were able to develop highly sophisticated features that with the money that we have in technical cooperation we would never have received. But those features, because it's for the complete system, now come to the benefit also of the countries in Africa and Fiji and elsewhere. And vice versa, the development, the intelligent procedures that we have developed together with our Nigerian colleagues, they came to benefit for the European colleagues, because then we already had the process model for contact tracing established. So that's a win-win situation, and the more countries use SORMAS and the more different partners buy modules or develop modules, it will always come to the benefit not only of the one who pays for it, but to the whole community. And what was the third question, please?
Oh, if you can identify new outbreaks or new diseases.
Yeah, new outbreaks, of course. So I would have shown that if I had that more time. We have this special module where we screen, or you can use the people and the software that screens social media, for example. Yeah? In Nigeria, that's established. They have a special team. There was a picture actually on it. And whenever they see a signal, or whenever someone from the hotline calls in, or there's something suspicious, this will then be led as a task. It feeds as a task into the system. It will be validated. And the good thing about it then feeds also back to the system and helps to validate those large social media screening tools like epidemic intelligence from open sources and all those different ones. So it's not so much itself that does it, but there is a clear interface to those procedures.
All right, thank you. Yeah, very nice being here, really, and also being reminded of some of the old stories many years ago. I also learned actually only yesterday that I was Rainer's first doctoral student 30 years ago, and I had the opportunity to meet those who might probably be his last doctoral students now. So that really closes some circles, and that's a nice opportunity. So I will in some way also follow up on what Gerard just presented here. I will talk about the so-called Corona One app. So that's about mobile apps as well. We stay in the realm of mobile apps, and we stay in the realm of early warning systems, but now it's about early warning not in the health sector, but of the individual that might be or that is concerned. And so my title here of my presentation is Navigating the Corona Pandemic Crisis and Beyond. How can mobile apps empower the individual and support public health services? And here in Germany, as in some other countries as well, it was decided early on in the pandemic that it might be useful to have a digital contact tracing tool. And there were heated discussions in the beginning whether that should be a centralized system or it should be a decentralized system. The centralized system would mean that information about contacts would be stored in a central database and analyzed there, which would of course give the health services and the epidemiologists much more data than a decentralized one, but would have a lot of privacy concerns around it, which are very understandable, would probably have a lot of acceptance problems. So in Germany, as in, again, most other European countries, we decided for the decentralized system, where the contact information is only stored and kept on the user's phone. This is also meant for us that we could use this Google Apple exposure notification framework for that, which was a feature built in the operating system of the iOS or the Android operating system and allowed to use the Bluetooth low energy signal exchange between the phones, and that's something that could run in the background, so you didn't need to have your app open or even have your phone active. It could run in the background and it would only have very low energy consumption, so you would not even notice the difference in your phone. The principles in the Corona Warn were two kinds of tracing. One is the proximity tracing. That means your device records which other devices are close to you, and then your phone would notify you as a user if one of the recorded devices that you had been close to turns positive. And turning positive means that the user of that device actually entered a positive test result, and that were uploaded the keys that you could then match to the keys that you had recorded. And that would be the case if you go beyond daily cumulative threshold of exposure by a certain proximity, a duration, and what we call the transmission risk. That's something that we built in the system here. That means we made an estimate of how infectious a person that tested positive would be based on some questions about symptoms and onset of symptoms. And the other feature is the presence tracing. That is, you're not looking at physical proximity directly through the Bluetooth signal, but you check into an event. So, for example, here, our symposium, we would check in here in the morning, and we would check out in the afternoon or evening again. And if any of the persons who were, of the phones that were checked in simultaneously at the same time, had a certain overlap of time, would then record a positive test, you would again get a notification on that. And that implies a call to action. That means this system was integrated with the testing system in Germany. So I start here at the bottom of the circle. You get notified, and with this notification of your exposure, you get some recommendations for behavioral changes. It could be anything depending on which phase of the pandemic we were and what the general recommendations and the health measures were. Anything between recommendation for contact reduction up to going into direct quarantine. And then you would also get the recommendation to get tested. In Germany, we had, or we still have, more than 10,000 test sites for the so-called worker test and the citizens test, which makes it very easy to access a test, and that could then, it would usually first be a rapid antigen test. If it's positive, it would be confirmed by a lab-based PCR test. Some people would get a lab-based PCR test straight away, especially if you have symptoms. And in recent times, we have more and more PCR rapid tests as well, so the point-of-care PCR tests. If you get a positive test result, you should notify your contacts through your device. And we are currently discussing, because the worker test system is probably scaled down in the coming months, whether we would also allow this notification of others through a positive self-test, which has some potential of misuse, of course, so we need to put some precautions into that system if we decide for that.
So if you are positive, you notify your contacts, you go into isolation, and the circle here is closed, so the next generation of people would be notified and go through the same circle again. All this happens more or less without the health authorities. So one thing that we decided for this system was because time, of course, matters, and that again early warning here. We all know that in many cases infectiousness of the individual starts before symptoms start. So a notification as soon as possible is very important. And then also this is supported by the test result. So you register your test in your app, and then you get the test result directly into your app. And it is in a way pre-loaded to warn others in the way that it's pre-verified by the lab server in the back end. And also you could give a pre-consent of sharing a positive lab result. That means we noticed in the beginning that people, particularly in the beginning of the pandemic, when getting a positive test, was much more of, let's say, a shock for people than it might be now, where you're used to it. So getting a positive test result at that time was not the best moment then to think about, should I warn others now, go through a consent procedure and things like that. So you could do that when you register your test. Give your consent of warning others if ever it would turn out to be positive. As I already mentioned, all this does not require any action by the public health services, and that had some advantages. Regarding the performance in times of crisis, so I'm comparing here 3 types of contact tracing, and we often forget, in addition to the conventional, or sometimes called analog or manual contact tracing, and to the digital contact tracing, we also have the informal contact tracing, which means that many people that test positive, of course, inform the people they know themselves, and they don't rely on any other systems. That covers, so this is done by the concerned individual itself, and it covers family and friends, so people that you know well. The conventional system is done by the public health authorities, the public health service, and it covers those people who can be identified. Often that is family and friends again, so who then turn out to be already informed by the individual, but that can be some additional persons that can be identified through the work of the health authorities. And the digital system has an advantage that it covers everybody who uses the app. And in Germany, that is quite a large part of the population, so we had more than 45 million downloads there, and we estimate, we have some ways of measuring that, about 30 million active users of those apps. When you look at speed, the informal system, of course, is very fast. The digital system is very fast as well. The conventional system is often slow, and it takes several days before you inform the contacts, and then it might already be too late. Regarding scalability, which is another important criteria in crisis times, is for the informal contact tracing, it's built in. The more people you get who are concerned, the more manpower or womanpower you have to inform others. So you don't need to scale it. The digital system is relatively easy to scale, and as we all learned, the conventional system is quite difficult to scale, and the public health services are quickly overwhelmed. Lessons that we learned in this process over the past years was the higher the incidence, the more the task shifts from the public health service to the individual, due to the reasons that I just explained in the previous slide. And for the mobile contact tracing app, that means that they have 2 aspects here. One is to decrease the workload of the public health services, and they can do that by reaching out themselves to the contact persons, provide already the information that they might otherwise get from the public health services. And in blue, I have 2 points that we should have in future, but we haven't had this time, and that is that we are able to give a more customized advice, preferably through an interactive or dialogue form, which really relates to the concern, to the notified person depending on particular vulnerabilities, on the local situation, and other things like that. And the other thing is also to be able to provide documents that otherwise, again, only the health services would provide, that allows you, for example, that orders you, but also allows you to go in quarantine, not go to work, for example, and to customize those, not this time for the user, but regarding the public health service. In Germany, we have 400 public health services. They all have different forms. They all want to do it slightly differently. And if the app allows this side of the customization as well, it gives it more acceptance by the public health services. The other way is to support their work, and that one part of that is the consented sharing of the contact diary contents. That we, every user of the app can have digital contact diaries that you fill daily, and that is also partly automatically filled over a 14-day period, and then the information is deleted. And if you consent to it, you can share that with your local health authority. And then also the consent to participate in privacy-preserved analytics. That means your app automatically sends some anonymous data to a central database, and here we get some of the advantages of the central system back again, because it allows us just to get an epidemiological overview also of the situation. And here just some results from that. So at the beginning of June, we had a little bit more than 50 million devices that sent daily data sets to the central database. And this is just very technical information here about what is actually the operating system used on that phone. And we see very nicely how new operating systems or versions of operating systems are trickling through the users. And it shows us that the system really works well, because this data is very similar to what the operating system providers also know about the trickling through of the new versions. When we look at testing delays, also comes out from the privacy-preserving analytics, we see that we can look at the distance, the time delay between the receipt of a warning and then the test registration, so that you follow up the recommendation of get tested now. And you see that really a huge majority of the people actually do a test within the next 24 hours, and then the second large group within 48 hours, but it may take up to 10 days before the decision to do the test is taken. And then on the right we see the delay between the registration of the test, and this is all for PCR tests only, and that the result is then provided to the app. And you see that is in most cases within 24 hours, sometimes up to 48 hours. When we look at what actually the red warning, the notification of the app user means in terms of exposure and risk of infectiousness, we can compare what was the state of your app at the time when you registered the test. So was it green or was it red, so to say? And what was the result of your test? Was it positive or was it not positive? This is on the left for PCR tests, and you see that, I don't know, is it a pointer here as well? Otherwise, well, you just see in the summer, those who had a red notification actually had a consistently higher level of positivity than those who had I need to explain the green one here also is a kind of notification. This is a notification beyond under the threshold. So it tells you you had been exposed, but you don't fulfill the threshold criteria for a high risk exposure. That's the green line, and the line underneath the violet line, that's actually the baseline of those who had no notification at all, no exposure measured by the phone. And then we saw that in this winter, all positivity rates went straight up, so everybody was exposed in a way. And it didn't matter whether you got a red notification or not. they all just had a very high positivity rate. It went up to almost 3/4. But what we saw then afterwards now that without a notification it's going down again, and for those who have a red notification it stays up at 3/4 of positivity rate. So there again it tells you that you actually had been exposed, that you have the risk of being infected, and it's well worth following the isolation as a quarantine recommendations until you know that you are whether you're positive or negative. And the same for the rapid antigen tests, or even more clearly marked, but on a much lower level of positivity, as one would expect. My last slide here. What we also learned is how important it is to build trust with the app users. So parts of that was it's an open source programming, so the whole code is available to everybody. We maintained a lively and critical open source community. We had a lot of audits, regular audits, regarding data security and privacy with the institutions that are responsible for that in Germany, and also partly with civil society. We do again because we hadn't had it, and we saw now that's something we missed and we should have had, is an advisory board, including civil society, so that also makes recommendations of what should happen with this app. Currently, for example, we would really like to have more input. Should we put it in some kind of summer sleep, or should we develop further features for autumn and winter? Okay, and with that, I'm through. Thank you for your patience.
Wonderful.
Challenge you a little bit in two regards. First is, you started off by telling us that your obligation was almost entirely to provide scientific advice and guidance. Then you showed us a slide that your organization is in charge of crisis management. I don't understand how those two statements can be consistent. And my second question is that you emphasize the primacy of scientific evidence, but in the case of a crisis like COVID-19, was your evidence entirely focused on the health consequences of the crisis? There were other consequences of the crisis. So what makes your evidence scientifically the prime evidence? How do we weigh and value the costs of the crisis that are not health costs, that are economic costs, mental, social costs, and so on? Evidence is always going to be political to some degree, because what you choose to measure and report is based on judgment about what you think is important. Thanks.
Yeah, thank you. Great question. So, first of all, we are responsible to file recommendations, and by these recommendations, the outbreaks and containment is managed on the federal state level. So we file the framework. We give the framework, and if particular federal states ask us to support them, but they have to ask us, we cannot come in by ourselves, we also will provide our support on the local level. Yeah? But our framework, the legal framework, is only, the obligation is only to make the plans, to give recommendations, to analyze the data, and out of this make as good as evidence-based recommendations. And one thing is very, very important to understand. Our legal obligation is only in the biomedical area. Yeah? So of course, when we made our recommendations, the risk of getting infected, of course, had a high priority for us. But as we are a public health institute, of course, mental health was also on our mind, and many other issues. But we don't have the legal obligation and mandate to put into consideration, for example, economical aspects. This is not our legal obligation. This has to be done by other parties. And this is what when I showed you this RIU model, so this should then come from other scientists. This is the integrative part. And this is something that you could talk in Germany and really make a case whether this was done or not. But our obligations is only in the field of biomedicine. And this is this is really important to understand. Yeah? So we are only one. We are a key player, no doubt about this, when it comes to containment. But of course, all the other things are on other duties. And this is what is very important to understand. So this is why we never criticized any decisions or any measures taken, because we are only in the field of biomedicine. But the politicians have the harder work to do, that's for sure. Yeah? So again, we are absolutely aware of all these other consequences. Putative, in the beginning, of course, there's not much evidence what will really happen, but it's expert based on the knowledge that you have based on your experience in the beginning. But these other consequences are not in our mandate.
Yeah, there was a hand up there.
Amy Cohen, and I'm a pediatrician working on the field. I have two questions. You emphasized informatics, which is a real big problem. We all agree, I guess. But in certain cases, like the COVID-19 pandemics, science was not ahead of things. We had to learn a lot. So science was also constantly communicating conflicting results, which gives a sort of what we call Nährboden, or what a field, which opens a field for informatics, which is dogma served, obviously, and much quicker. So what can we do about it? I want to give two examples. The use of masks. It was communicated that they wouldn't work in the beginning. And the second one, which really hit us badly, was what was communicated in terms of vaccination for youngsters and children. So how can we explain our patients if the STIKO, for instance, says for a period of 2 months, 3 months, that they shouldn't be, or if they want, they should, and then suddenly they have to. So I find this very difficult, and I wouldn't know what the solution is. And my second point is, I think it is just an idea, and I would like to challenge it, that science and politics have to be kept separately, because it might be right what you say, but it is a fiction. Even what we do in science is biased by our ideas, by our priorities, and whatever. I mean, we had a lot of money going into the COVID-19 research, probably not for ages into malaria. So, I mean, what is science, what is politics? Can we ever divide it?
So more questions quicker than that, he can run more fast here. It's a good public health exercise. I disagree on the first, on your first challenging. Science always is developing based on new findings that you have. And of course, it is simply not possible to always explain why something has changed or didn't change, because you're getting new information. And this is used by various players, stakeholders, for own reasons. Yeah? To make it very clear, you can never solve this problem. It has never been said that masks are not helping, but in the beginning what was said is that masks only, in the beginning we didn't know that this virus was spread through aerosols. So in the beginning we were thinking that these viruses was only spread through droplets. Then, of course, from this understanding, only those people who are actually infected and are sick spread viruses. So these should wear masks. And this was, I mean, you can go through all the documents and can just only now talk for the Robert Koch Institute. You can go through all documents. We have them since 2.5 years. So it was recommended for those that are sick to wear masks and stay at home. Then we understood that aerosols play the role, then these masks were recommended. That's a very easy thing to say. STIKO, I find it particularly, I have to say, astonishing that you challenge STIKO. STIKO does only recommend. So they never force anybody. It's not a mandatory vaccination. They only do recommendations. It's very clear. You can read the texts. There's a different story when you listen to media that try to interpret what STIKO says. Please always go, and this is very important for all of those here, go to the original source of information. They're only doing recommendations, and they're explaining why they're doing this recommendation, because they are highly based on evidence. And they could only recommend when they had enough data to do it. And in the beginning, it was very, very clear, you didn't know how big the impact of the disease in children is, and you didn't know whether the side effects of the vaccine would do more harm than vaccination in children. So this is not suddenly they changed their mind, but they are working constantly on it. And this is a huge difference. So the second question I forgot, to be honest. What was the second question? Was war die zweite denn? Also, yeah, sure. That's what I mentioned. There have to be two different entities. It's very important. That's why I'm stressing independence of research so much. Of course, they are influencing them each other. This is obvious, but of course, there should be as independent two entities as possible. They have to talk to each other. They have to make up minds, but they have to be very independent. That's very important. If this doesn't work out, we are in trouble, because you contaminate each other. Politicians contaminate scientists, and scientists contaminate politicians. And this is something that is maybe really dangerous. And you can nicely look this up in our federal countries, our federal states. You will see that different federal ministers, different minister presidenten came to different conclusions because they were advised by different scientists. A very, very interesting finding, although we had the same situation all over the country. So I very much agree they have to be as independent as possible. But the politicians have to take the responsibility for the decisions. They are making the decisions. And the decisions are not made by scientists.
I think he raised his arm for longer, sorry.
Thank you for your presentation. Really fascinating to see the evolution over time. I'm just wondering, in terms of science-based and evidence-based decision-making, what was the science that led to the imposition of sanctions related to travel of South Africans to Germany? For beta, okay, but so why did the RKI then recommend sanctions? So there was no recommendation of travel sanctions from RKI?
No recommendations. What we had to do, we had to declare which of the countries had what different state of infectious diseases, whether they were whether they had certain variants or not. Yeah? That's very important. We had the task to do this. The sanctions were never recommended by the Robert Koch Institute.
Yeah, thank you. Kevan Bozogmer from School of Public Health, Bielefeld. First, thanks of all for all the hard work that RKI and the colleagues has done the last 2 years. And thanks for making the... Yeah, I think we're challenging you a little bit at the moment, but I think it's also important to say a few words of thanks to all the hard work. But I would also have a question. I think thanks for making the strong case for independence of the evidence and the advice to policies. But do you see any tension in the architecture where RKI is built? I mean, you're sitting directly under the government, under the MOH, and so there are other political influences as well. There is evidence that some of the recommendations, for example, for refugees, have been, delayed, watered down through political influence. And what tensions do you see there in the sense of, being able to operate fully independently in this architecture? Thanks.
Yeah, there are many tensions, obviously. Yeah, I mean, I guess there can't be any institution that has more tensions than the Robert Koch Institute. So to be very clear in the biomedical area when it comes, because we are under the roof of the ministry, and there is a certain legal mandate that in principle, to make it very clear, in principle, the Minister of Health could give me, what I said, he could force me, he could order me to file certain recommendations. From the legal aspect, he could do so. But each and every of these ministers is smart enough not to do it against a scientific background. Because in the end, this would be clearly, openly documented, and because we have a society where journalists can look into all documents if they have an interest. We have an information freedom law. So basically, this would not be possible in the long run. But there are many tensions, yeah. And I don't want to talk about all these tensions here openly, yeah? But there were many tensions. But the most important is that you stick to the scientific evidence. That is very, very important. And that's what I meant. If you don't have a strong institute with strong scientists that you can rely on, that you know that you have a backup from the people in your institute, how can you as a person have all the knowledge to have the best knowledge what to do? If you don't have an institute that is scientifically really strong, you basically have no chance to resist these tensions, to make it very clear. And again, very important, we are in a system of federal states, and there are many stakeholders that put tension on you. And they may play with all what they have, yeah, to force you to change your mind. They may do it through media, using certain media to destroy you, to try to destroy you. Whatever you can think of, it's possible that it will happen.
Well, thank you very much for those presentations. I think we're going to shift gear back to the presentation schedule that we had before. And this will mean that we will probably be finishing, my guess, by about 4:15. So it'll be slightly later than was programmed. Yeah, is that all right? Well, in that case, the next presentation is going to be given by Annelies Depot, who leads the Centre Virco Villerme. I hope I've pronounced it correctly. And she's going to talk about being aware yet unable to act, which is a very tantalizing title, and I look forward to your presentation.
This intervention aims to explain an apparent paradox. We know the dangers associated with climate change, yet we seem to be unable to act to mitigate them. So why is this? I will seek to provide some answers that can help us move forward. For this, I will suggest two avenues. First, the importance of stressing the co-benefits of climate action for health, then reflecting on the lessons that can be drawn from our responses to COVID-19. I'm neither a physician nor an epidemiologist, but I hold my PhD in information and communication sciences. And to use a medical metaphor, my discipline auscultates communication disorders. And what I suggest you today is to deal with our climatic apraxia, which could be summed in this formula, being aware yet unable to act. So I hope to establish with you the diagnosis of our contemporary apraxia and consider new pragmatic modalities. So June 18, last week, Europe is affected by a heat wave which impacts the health of populations. The way in which several media illustrate information offers another narrative. Take the German press, you can see images of people having fun in the sun, kids splashing in city fountains, crowded beaches. Whether in Germany, France or Belgium, the media have obviously drawn from the same image bank. On social media, the media itself was outraged that some media illustrate the heat wave with children playing in fountains. So, how the media communicate about climate breakdown reflects and shapes how societies engage the issue. Images of the climate crisis can hold a power to change our collective psyche, something the Guardian recognized in its sector-leading 2019 editorial decision to rethink the images. Images are a key part of any media communication. They are often vivid and colorful, drawing readers in and helping them remember a story. For a long time, the polar bear on the melting sea ice has become an icon of climate change. The framing of climate change can make a difference, and the second image of a cracking earth is another popular way of depicting the impacts of climate change. But these two images only reinforce the psychological distance. Understanding the complex phenomenon of climate change cannot be limited to figures, statistics, and mathematical models. To understand and interpret the many meanings of climate change or physical origin, it is also necessary to resort to the way in which this change is described in words, discourses, images, speeches, comments, information sharing. The images that I have compiled contribute to fueling the discourses on climate delay. Discourses of climate delay pervade current debates on climate action. These discourses accept the existence of climate change but justify inaction or inadequate efforts. A recent article identifies, describes, and categorizes discourse of delay. The sophistication of discourses of delay should therefore not be understated, and new strategies are developing all the time. The Eurobarometer survey from July 2021 gives an interesting picture of the high silence regarding climate change and health impacts in terms of perceptions. For the first time, climate change ranks first as the single most serious problem facing the world as a whole. Taking into account the deterioration of the environment as well as health problems related to pollution, 29% of Europeans consider climate change to be the biggest current global issue. Most people think climate change and sustainability are imported problems, yet climate action remains insufficient. Why is that? Structural barriers such as climate-averse infrastructure are part of the answer. But psychological barriers also impaired behavioral choices that would facilitate mitigation, adaptation, and environmental sustainability. In order to create a shock effect, the star presenter of the weather report in France presented the climate scenario of a certain August 2050, so 8 years later, a scenario that seems futuristic to us has already become a reality. Yes, individuals underestimate risks such as those related to climate change and COVID-29 until after they experience the consequences of the disaster or learn about friends or family who have suffered from the threat. This underestimation is caused by the availability bias. Empirical studies find that individual concern about climate change and willingness to adopt mitigation measures are positively related to experiences of climate change related risks such as flood events. So the availability bias is especially problematic in the case of climate change, which is not silent to people unless they experience its effects, such as more frequent flooding due to the sea level rise. Twitter gives an interesting picture of the shift in terms of perception of the impacts of climate change. Have a look to a recent study published in the last Lancet Countdown report. One of the indicators tracks the effects of heat waves on the general sentiment of expressions from Twitter users around the world, offering a glimpse into the influence of heat extremes on the sentiment of people around the world. The indicator classifies the sentiment expressed in more than 6 billion geolocated tweets collected between 2015 and 2020 using the linguistic inquiry word count sentiment classification tool. Local heat wave exposure was found to significantly reduce positive expression and increase negative expressions. The Eurobarometer survey, here it's interesting to show that this survey show that 9 in 10 respondents in France agree that tackling climate change and environmental issues should be a priority to improve public health. Moreover, close to 7 in 10 respondents agree that the cost of damage due to climate change is much higher than the investment needed for green transition. So, more specifically, respondents in France are more likely to buy and eat less meat and to buy and eat more organic food. So co-benefits could be a powerful way to take action on climate change. So eat less meat, active mobility to avoid cardiovascular disease is also very powerful action on climate change. And a paper from Alina Herrmann, Dorothee Amlung, Ellen Fischer, and Rainer Sauerborn makes the case for a more positive communication based on the co-benefits that exist between climate action and public health. They argue that such framing around the co-benefits of climate action for health can help overcome key cognitive effects in the communication of climate change, and on the basis of an empirical study conducted in 4 European countries, France, Germany, Norway and Sweden, they show that such a strategy can yield significant behavioral changes. So one way to summarize my intervention is to put our subject into perspective in the context of the COVID pandemic. In the spring of 2020, the world had to deal with the COVID-19 pandemic and implemented radical measures to contain the spread of the virus. Many activists on climate change were quick to suggest that the measures implemented to fight against the spread of the pandemic had to be replicated to slow down climate change. Here we must respond to climate change like we are responding to coronavirus, have we heard. Climate change and the COVID pandemic are not similar crises, even though they present some striking similarities. This has important consequences for the response measures to be deployed, but also for the way we communicate about climate change. First, if people were so much more afraid of COVID than they are of climate change, this is probably because they were afraid of getting sick ourselves. Central elements of the response lies in the proximity and immediateness of the threat. We are all afraid, or should be afraid, of contracting the virus personally, while climate change still seems perceived as a concern for others, for the next generation, or for far-away countries. Here, it is important to ponder as to why we maintain such a psychological distance with climate change and the responsibility we hold as researchers. Climate models are calibrated on the long run, and policy objective targets 2050 or 2100. Yes. On the contrary, we were presented with daily curves of the COVID spread, how many had died, how many were in intensive care in hospitals, etc. So we had daily figures for the COVID, and we have curves that stretch until the end of the century for climate change. Research has consistently shown that the arguments about the public health impacts of climate change were amongst the most persuasive and most likely to induce behavioral changes. Obviously, the COVID crisis provides empirical evidence of this. People were ready to drastically change their behavior and stay at home to protect their health. And they were going so because they felt this could provide immediate benefits for their health. It could prevent them from getting infected with the virus. The media window for coverage of climate health nexus has expanded considerably in the last few years, and we expect that this window will broaden even more after the COVID crisis. A great lesson of the crisis is that government can implement urgent, radical and costly measures in the face of an imminent danger. Therefore, it would be tempting to assume that similar measures could be replicated against climate change, as they provide exactly the emission reductions that would be needed under the Paris Agreement. Yet it would be an important mistake, I think. The reason why confinement measures were widely accepted, through not also always perfectly applied, it is also because they were temporary. So we should be very careful about treating climate change as a crisis. A crisis is temporary and suggests a return to normality at the end of the day, and global warming is an irreversible transformation of the Earth's climate. There will be no return to normal. Temperature will not decrease, sea level will not go down, at least not for a very long time, and there will be no vaccine against climate change. Yes, so concerning so preparing the next session, I provided 2 research questions, so I like to have a look at this, and then we can discuss about it later. Thank you.
Fantastic. Good afternoon. It's a true pleasure to have the honor to be here. I'm the founder of Digital Trust Analytics. This company is a result of my academic research funded by the EU Commission on the EFRE Fund, to be specific, on building digital trust. I was sitting in a meeting developing a digital health tool, and there we were sitting together, and there were a lot of believing, assuming, and guessing. And I was really curious about this cannot be the way how we are developing trusted digital health solutions. So that was the motivation for me to write the proposal to the EFRE Fund, which was luckily successful. Today I'm talking about positive framing works in communication of COVID and climate change. Trust can be earned and it can be built. Well, we already have heard this term trust several times, also from Mr. Wieler recently, but what is trust? Trust is one of our most complex feelings. It is a management summary of the current situation we are in, all the experiences we have made in our lifetime, so all external sensory experiences, all current in the situation internal sensory experiences, and it enables us to make very fast decisions without using that much own computing power, right? And I've systemized it by using the Maslow pyramid of needs. Maslow is a very known concept, so I use it. So I use something the majority already knows, and then add something new and to structure digital trust building. This picture is focusing on digital trust building in digital solutions, but it also can be transferred to other areas. So when we start here at the bottom line, first we start with correct non-biased data. I was so impressed how much data all you already have presented and you do have. This is science therefore, and we have heard it yesterday from our Minister of Health, evidence-based politics that the C is looking for, and therefore that we are needing science. And science here is very crucial, and explicit non-biased data, and developing non-biased data is really an issue and hard work. Then we need efficient and effective processes. So how can we analyze the data and enable politicians to make here the right decisions? And we are coming to the next level, the license to make business, right? This is cybersecurity, GDPR, regulations, ethics, data policy. Then the next level, fundamentals of trust, controllability. We humans will love to have the controllability. cognitive controllability. I'm referring later to your really fab work. I really enjoyed reading at Helen Fisher. Now, this is important. We are humans, right? And give the human the ability to control a digital solution and also the information you are providing. We love it to have the cognitive control. When information is too complicated, we are losing very fast trustworthy. Also, Cayman has published here several articles on this issue. And then we are coming to the next level, consistency. And point which is very important are decision architectures and decision methods. How are decisions being made in politics? Which decision architectures are being used? Well, we humans, our ability to make decisions is highly variable. It really depends on the day and the time. And sitting around a table without a proper decision method, it's not that helpful to enable us to make really the best decisions, right? And then, the next level, benefits or belonging. Every human will love to gain a social status, and it's very easy to motivate humans to adapt the wished behavior into climate change or health when they do have the opportunity to develop a specific status, right? We love to gain status. We are humans. That's the reason why we always build out hierarchies, right? We love to climb up a hierarchy. We cannot change humans, but we can understand humans and use the biases and the abilities humans have to build better systems and to make better, efficient politics regarding climate and global health. To influence human health and climate behavior, effective communication really needs to be done. And I'm now referring to a wonderful study conducted by Rainer Sauerborn and Helen Fisher. So authentic communication can only generate the expected effects if primary data is easy, understandable. When we look on the Intergovernmental Panel on Climate Change, on their annual reports and the process, how these reports are being generated. First of all, it's a highly interesting process, but it involves a lot of editing. So the reports, of course, are very long. And the language style is very academic. It's very complicated to understand. And it's very rich in information. And the whole process of iterations leads to very complex written and visualized data. That's a problem when it comes to political decision making, right? When we look at these data visualizations from the 22 report, it's very hard to understand. Humans love to have the cognitive control of information, and making really academic data easy understandable really would help to motivate people to make better decisions based on these reports. Then I'm coming to the summaries of policymakers. Make them brain-friendly. Our brains are tired. We are getting so many informations, impulses every day, right? And as policymakers, they are busy, their teams are busy, they have so many things on their table. All these recommendations really need to be brain-friendly. That means easy understandable, easy to adapt, and really accessible. Yeah, cognitive controllability. Here's a quote of Kahneman, Nobel Prize winner. I'm sure everybody knows him. He's referring very, very clearly that also academic data really needs to be easily communicated very clearly and specific. Then it is easy for us, much easier for the broader public really to accept it. One very nice example is airline cockpits. I just had, already 2 years ago, a very nice project with Airbus, and how the data is being displayed in airplanes, airplane cockpits, is very, very well researched. it very precisely analyzed in which situation, which data needed to be communicated in which way to enable the pilot to make the right decision in the right moment, right? And so really from cockpits we can learn a lot. Interdisciplinarity really can help us to make better decisions in health policy and also climate policy. Use a whole and very target group specific tailor-made media. We have already heard about it. I'm not going too deep here. Of course, mass media, internet, news pages, blogs, social media. Analyzing the communication during the COVID-19 pandemic in many European countries and also other countries was missing target group specific communication in social media. Whom do you reach with television communication? Well, in Germany, you're reaching the people who are over 60 years old. Younger people, you will reach them on Instagram and YouTube. And for that, you need the influencers who are able to reach the people in the language they are able to understand, they like to hear, and by their opinion leaders they like to follow. Especially micro-influencers who are just only able to reach 10,000 or 20,000 people. So, this is one social media posting which was very, very successful. It was honestly one of the most successful ones based on clicks and views. It has been posted by Petco. Petco is the world's leading company for animal health. A bit surprising, but yeah, but it was a useful tool. What question do you have about pets and COVID-19? There you could type in your question. There was a very good bot behind, and the bot answered really properly and accordingly. That was a useful tool. And people who have pets are belonging to a very specific group. The probability is very high that, these are really caring people, right? And probably it's very unusual, but when you realize that a communication strategy works, like in this case, oh, how can we use it better to be more efficient? This is just an invitation to be a bit more creative when it comes to public policy. Why use research on health communication as a guide for research and climate communication? Health and climate communication, both are super complex topics, super complex. Second, both topics are highly probabilistic information, right? We are trying to predict the future. And thirdly, human organizational behavioral change needs a lot of effort. Humans don't like to change because learning is a high intense energy effort for the brain. And we love to run on our system 1 to refer to Kahneman, and system 2, well, it's a lot of effort also to implement new behavior, really to become automatic system 1 behavior. But we can combine both issues, climate and health. And really, I'm again referring to your wonderful work, Helen Fisher. I loved reading this study. So what makes behavioral change difficult? First, health. Effort to change the behavior affecting personal health, right? And when we have to change our behavior, we are reducing our dopamine release. Dopamine is one of our hormones which is motivating us to do things, right? It's also often called pleasure hormone, which is not that correct, but we leave it that way. Then climate change. Decisions by large accounts of scientific uncertainty, but we are very certain that it's really, really terrible what's going to happen, or what's happening already right now. The effects of climate change will not address our personal lives here in this region. So we need to do things which are for the next generations. And humans are much more easier to motivate with things which they are profiting directly in their life. And thirdly or fourthly, decision makers will not be personally affected by the outcomes of their climate actions or inactions, right? Political leaders mostly think in these 4 years legislation terms, and this is a problem. Several methodologies and strategies exist to enable us humans to change behavior we are profiting directly. Health science already provides a set of proven concepts to change our decisions and behavior. This combination of two vital issues, health and climate, really would make a difference. Evidence-based climate communication and that cognitive psychology can deliver such evidence proven by Sauerborn and Fisher. The study is the first to show that providing information on strictly unconditional individual health co-benefits can motivate households in high-income countries to adopt climate mitigation action. And this is really amazing because the high-income households are responsible for around about 70% of greenhouse gas based on their consumption behavior. And health co-benefits occur directly to the acting of individual. They are private goods rather than public ones. The evidence base for magnitude of health co-benefits is well established, right? Especially in the well-educated households, it's already good ethics to live a healthy lifestyle, to do your exercises, to eat well. It's really established, especially after COVID-19, or still during COVID-19. I'm sorry, it's not going away. The idea of healthy lifestyle is well ingrained in the public discourse, much more than that of climate-friendly lifestyle. Well, climate-friendly lifestyle is coming, but and private households have been identified as the key actors in global climate change mitigation, right? So, to summarize, I'm not going that detailed in the research data because you have seen so many data already. What has been proven to be successful are, I summarize, package deals, right? So they have, the cohort was at 309 households in 4 European Western countries, high-income households, and and they have given them the advices to live a very specific, more healthier lifestyle, and these measures were also very climate friendly. And the adoption rate was really, really significant. So when the co-benefit of a healthy lifestyle and climate change is being connected, the adaptation is very, very high and has an impact. And package deals are very known by us, they do work, and we combine, oh, time is running. Okay. I was just warming up, I'm sorry. So, positive framing excurs Denmark. There was a wonderful study conducted by the University of Copenhagen. It's a Department of Political Science, the HOPE project. And sadly, they have identified that the Germans are are not trusting that much their health authorities compared to Denmark. And in Denmark, people have been faster in adapting the COVID-19 measures as well as the vaccination. What was the reason why, right? The reason why was, first of all, the trust level was much higher, and there was a strong positive commitment that we are doing the right thing for us. That was a core message when it comes to positive framing. I'm closing with a very short, brief view to Chile, which was also very, very successful when we look at the speed, the vaccination speed and the commitment to the COVID-19 measures. They had the core positive framing. It was not that positive framing, but they said, come on, let's get vaccinated, follow the measures to get the lockdown have an end, right? And these are two wonderful examples, Denmark and Chile, we could learn from. And here, this is my company. And I'm highly looking forward to answer your questions.
Good afternoon from my side. It's really a privilege being part of this symposium. And let me share a few thoughts on how, as a scientific community, we might think about how we might be able to improve the impact on society that we are having or could potentially have. Let me start the presentation with a reference to this gentleman here called Vannevar Bush. So he published a report called Science, the Endless Frontier in 1945 to the then President of the United States, Roosevelt. And this document lays the central claim, arguably, that underpins science policy post-World War II, which is science will ultimately lead to applications to the betterment of society. And this idea, led to the foundation of the National Science Foundation in the United States, strengthened the mandate for the National Institutes of Health, which till today is the largest funder of science globally with a 14 billion budget a year. And arguably, COVID is probably a very good showcase for how powerful science can be for the betterment of society. But let me challenge us as a community a little bit. Rector Eitel yesterday in the introduction said it's really important for us as a scientific community to overcome ivory towers. And so if we think about impact in science as scientific community, how do we, measure impact? And in our community, what really counts are citations to our scientific works. And citations, by definition, only capture how the science community in and of itself receives scientific findings and acknowledges them. And if we take this a step further and we think about how citations evolve over time to scientific works, so you see here on the x-axis, you see years since a publication has appeared in the open, and on the y-axis, you see how it accrues over time. And so you see here that, within the first 2 years, you have roughly a quarter of the citation potential being reached. After 5 years, you have roughly half of it. And if you continue this a little longer, you need sort of 10 years, then you're at 80%. So it takes time, right? And again, this only captures how we in our community receive this work. This does not capture how broader society receives our work. So what if we would have an alternative metric available to us that complements this view? Because this view is undoubtedly important, right? But how would we think about having an alternative metric that might be able to capture, our ideas faster and the impact our ideas might have on society? And so the answer is there is an alternative metric. More recent, obviously, less established, called the alternative metric. It's also referred to as, an attention score. And as you see here, compared to citations, it accrues, much faster. So within the first year, you have almost the full potential of attention a scientific article can get. And if you were even to look into this intra-year, you would see that this score accrues within 3 months, 6 months very rapidly. And so the last point I want to make is, so this citation line that you see there, it's not a random citation line. This is actually a line drawn from a population of elite early career scientists out of the United States that have received the National Research Service Award by the NIH. So these are people that are poised to have impact in their fields. And it takes time. So what is this alternative metric? So here is an article in Nature Medicine published in March 2020. That was the article that received the most public attention in 2020, as indicated by this altmetric score down here. Not surprisingly if you read the title. You can click in Nature Medicine directly to the altmetric score. You see here then on the left, you see a badge with different colors. These colors introduce you to the sources of where attention came from. News, blogs, policy documents, Twitter, different sources. So each color stands for a different source of attention. If you scroll further down here at the example of Twitter, you see this article has been tweeted 70,000 times. You can look at the geographic locales where the article has been twittered worldwide. And if we scroll a little bit further down, you also see, apart from the geographic location, a demographic breakdown. So who twittered? Is it members of society? Is it scientists? Is it science communicators? So there's a lot of information in here. If we go further up for policy documents, just as a second example, when you click on policy documents, you see the article has been captured by 7 policy documents already. And here's one example for the World Health Organization in January 2021. And so we even have the ability to even measure how long it takes for science to translate into policy documents. So in case of this article, it's 290 days exact. And we can do this at scale. We can do this for all articles. So this score actually tracks over 20 million of research output, and we can all, as a research community, assess this information. So I strongly encourage you, take a look at this whenever you have some spare time. Think about research questions that can come from this data, because there are plenty. You can think about, where is science created? Is an article that's created in the United States that is about problems that face the global South actually taken up by media in the global South or not? So there are tons of questions that we can think about here. Going a little bit into the theme of this symposium. So this year is actually showing on the x-axis the years, and on the y-axis the average altmetric score that articles on climate change have received. And just for the symposium, we identified articles where climate change as a term was either in the title or abstract. And so 2 things you might take away from this chart. One is there is an increasing tendency for attention paid to articles, scientific articles about climate change. The other thing you can glean from this graph is this gray line here. This gray line is basically capturing the average altmetric score across all scientific articles tracked. So more than 10 million articles of similar ages roll into this average score at the bottom. And so you can see climate change research gets more attention than the average scientific article. If we zoom in on these yearly views and we take a look at the monthly scores, so now the same graph as you had seen before, just split by monthly scores, and the vertical lines here in gray dashed are just separating the years. So when you look across the years, you can see that there is the increasing tendency that you had seen on the slide before. What you've seen within month, when you look within year across month, you can see that there is a tendency for the score to spike at certain occasions, and it tends to coincide towards the final quarter of a year. So just some suggestive events that happened. It's really suggestive. We have just started to look into this data. So here you would see, the COPs tend to be in the last quarter of a year, for example. You also see here where you might have a small anomaly here in terms of the month here, which is a little bit earlier than the other spikes. You had the IPCC special report on the 1.5 degrees that came a little earlier. But what's probably most striking about this graph, in terms of a research question for us as a scientific community, is when you think about that this measures the attention the article has received that got published in this month. So if you happen to have published an article that was in the month of a COP, you might receive more attention. So is this strategic? Do journals, place a strategy on when to publish an article? Probably, probably not. Or is it just reactive media coverage to something like this? And if that's the case, how can we as a scientific community think more strategically about how we might be able to communicate findings that we have, instead of having perhaps a very reactive graph? Now, if we take the second component of this symposium, so climate change and COVID. Now, if you think about how COVID has garnered, and rightfully so, much of our attention, this is how this graph looks like. The blue bars are the exact same representation that you had seen before. The COVID attention is in purple. So you see what a difference this is. Understandable, perhaps, but also very important for us as a community to be aware of. Understand how we as a scientific community get, perhaps displaced in terms of attention for periods of time, rightfully so. Perhaps we can also say this is an influx of additional attention, right? It's perhaps not displaced, it's just having activated more interest. We also had, throughout the course of the symposium, infodemics and rampant disinformation. We can also, as a community, look at this data and inform questions about that. Now, I had only shown you the climate change data up to 2019, so this is 2021. So it declines, and if you were to extrapolate the trend from the year earlier, you would have seen a graph like this. So it's just about awareness of us as a community, how our research can be transmitted into public space. And this here is the pre-final graph here, just to also save us some time for a discussion. So this here is in the life sciences as a field, perhaps, the most affected field in terms of attention, rediversion, displacement. So on the left, you see fields that have received more attention in connection to the COVID crisis. On the right, you see fields that have received less. So these are, if you just rank it agnostically, so these are the top 10 and the bottom 10, if you will. Just agnostically. Comparing, articles that have appeared, in 2020 versus before COVID in 2019. So to conclude, I want to share two observations that I think might be takeaways for us as a community. So altmetric might be a complementary measure for how we think about the impact our science might have. The second one is COVID showcases how attention, which is a scarce resource, might get redistributed, or we might be also able as a scientific community to draw more attention to our work. And these are the two questions that I have on the right that might spark interest in this room. Perhaps you take it to others. What drives attention to science? And if we understand that a little bit better, how can we make use of that? And the second one is, do changes in attention that we have today might influence the course of science tomorrow, if we think about what happens to funding, for example? So those are the two questions I want to leave the audience with, and thank you very much for your time and attention.
So, thank you for the invitation to be here. I'm very excited to be part of this conference. I'm going to put a few disclaimers here because I'm probably the only one who's not a scientist in the room here. I'm just a regular consumer who is probably damaging the climate without even knowing it, and also not fully aware of the public health. And so over the summer, I thought, what is this with climate change, and is this even real? And I thought, where do I go? Because there's so much fake news, and there's so much media, and there's so much buzz about it, but where do I go in order to actually learn what is really going on? Because I've seen it earlier, it's getting warmer anyway. We had glaciers years ago, or decennia ago. So I thought, as an employee of edX, I go to science. Because we partner with fantastic institutions like yourselves that actually put courses on our platform to share their science and share their knowledge. And that's how I took one course about fake news and climate change. I took another course about renewable energy. I took another course about nuclear energy. I took another course about just in general, what are the challenges and how does the funding work and how do the government challenges work. And so I'm proud to represent edX, an online learning platform. Is this going like this? We're hosting over 4,000 courses on our platform and 45 million learners around the world. Our learner population is, the majority is 25 years or older. So we're reaching quite a large audience other than just the scientists. And we partner with over 230 academic and corporate and governmental institutions around the world. And so here's a snapshot of some of those institutions that we work with. I should have definitely put the Sustainable Development Goals Academy here as well, the World Bank, and some other great institutions that publish content on our platform, in particular about areas that are so relevant for this audience. And so what is this platform about? So we started as individual open courses, the so-called MOOCs, and then we built out courses over time into professional certificate programs. We started experimenting with credits into micro-masters and micro-bachelors. We are a combination with 2U, another digital learning partner operating in the space that offers full degrees online and boot camps. And so we offer a platform of all sorts of different learning solutions for individuals like myself who just want to learn, but also individuals who don't have access to education and are not as privileged as we are being in this part of the world and actually get partially or full degrees through the power of online education. So I heard a lot about impact. We're also all about impact. 80% of our learners complete the courses. What is it again? 2.3 of the learners take at least 2 or 3 courses. Well, I bumped up the average score a little bit. And then 91% of our learners reported positive career outcomes. And so here are a few examples of those learners. You know, what they've taken, the courses that they've taken, and how they actually landed a career. An individual specifically that took an executive education course from Cambridge University in sustainability management and moved her entire career in that area. Individuals in the US who were truck drivers and took a micro-bachelor's program from the University of New York and landed a career in supply chain management, and people who completed full degrees online. And so what did we do, for example, during a pandemic? Not to offend anyone, but universities are very conservative and mindful of doing the right thing and take their time to do so, right? So during the pandemic, we with our consortium of universities said, we need to do a few things here. So we ourselves launched a course, How to Learn Online. We built that course, put it on the platform because suddenly everybody was in lockdown and wanted to learn online. There were a few Stanford professors who said, oh, all this remote working, it's taking a mental toll on all the Zoom and lack of human connection. Let's create a number of courses about how to bring in humor in the virtual workspace. But then the most impressive one that I'm personally very excited about is the course that Harvard launched, and I think they did it in a few weeks' time. I still don't know how they got funding. They built the course in a few weeks' time, put it on the platform, and it went viral. In, I think, 24 hours, we had 300,000 enrollments of people around the world, practitioners who shared it, and then they translated it as well to Spanish to further enhance the reach. So we can move fast. This is another example of how we're trying to build impact. For those of you who don't know, edX is built as an open source, it's built on an open source learning platform. And we provide the world with that code. So you may have heard of Open edX. And so the Ministry of Education and Science of the Ukraine built their own platform to continue to help the continuation of their learners, and not only the kids but also their students, to continue to learn not only during the pandemic but also now during even more potentially more challenging times. So we were talking about how can we make impact as science, and what can we do? We're publishing these great papers. We have all this knowledge in our heads. We're teaching, but are we teaching in ways that still resonates with learners? And how can we enhance that impact? So I thought of sharing a few trends that we're seeing that we call the learner-centric university that I'll talk you quickly through. Because I also know, based on science, our attention span is only 6 minutes, so I should really keep it short. So 4 trends: broad adoption of online lifelong learning. So all of us continue to learn. And prior to the pandemic, if you only know how many conversations I've had with universities about the effectiveness of online learning, I think the pandemic helped us to understand that that there's a much quicker adoption right now. The growth of modular and stackable learning. We don't need for everything a degree, but we do need science and continuation of learning. And then shifts to blended learning on campus. And lastly, the mapping learning to career relevancy. So real quick, we've seen that 68% of our learners prefer non-degree programs. And that is compared to 50% who preferred them before the pandemic. We know that the pandemic really accelerated online learning. And it's not always that we need a full degree. A micro-credential, a number of courses can do the trick for us as well. So what do we do with modular, stackable learning? So what we've experimented back in 2015 was how can we give credit to online learning courses? And we started with Arizona State University to do online proctored examination. And we had a model where students could take the courses for free, and if they wanted the credit-eligible pathway, they had to upgrade and they had a specific track. And then we started in 2017 with MIT to pilot a micro-master's program. That was part of a full master's degree. We don't get credit, but we as a platform don't give the credit, but the students who complete the program successfully get, upon admission of the rest of the program, the 25% that they've done on edX converted into credit. So it's an accelerated pathway, but it also has a career relevancy for those who don't pursue the remainder of the degree. So this is an example where Cambridge University had a humanities micromasters. They were experimenting, and they had such big success that they are now launching the micromasters as a mandatory part of the remainder of the master's degree. So it is basically a funnel for the remainder of their degree. So this way, it's not only serving the learner, but it's also helping the university to rethink the way they've been teaching and how they can actually repurpose some of the things that they're doing for multiple channels and audiences. So the shift to blended learning on campus. So this we've actually been seeing, in particular in Europe, quite a bit, where publicly funded institutions would put courses on the edX platform and also repurpose some of those materials back on campus. Prior to the pandemic, there were some early initiatives of MOOCs for credits, where universities with the ECTS system would grant each other's courses for credit. But during the pandemic, again, we said we have to do something, and we moved fast again and provided our entire catalog for free to every accredited academic institution in the world to help continuation of learning. And so we've done that and gathered data and information on what universities need in order to adopt courses from other universities on campus. Because if you're the issuing institution of the degree, you want to make sure that you have the rigor that you're standing for. So we built features and functionalities in the platform in order to do so. And 7 out of 10 faculty members said that, this is actually not that bad. And we'll continue to, now after the pandemic, we'll continue to blend the learning on campus. And then 50% of our students as well feel much more optimistic about courses that combine the two modalities. And this is an example of a Turkish university that uses the edX catalog that doesn't have for all subjects and discipline the faculty, but uses those courses on campus and then facilitates the learning, does the examination and gives out the accredited degree. And then last but not least is mapping learning to career relevancy. So what we've shifted in doing more and more is mapping various databases into the course development of our universities. So we look into what are the skill sets of the future. Good news for you, we see a 30% growth in sustainability and global health type of courses. So we're working on building that catalog and looking into what are the necessary skill sets that people need to learn and how can we support schools in providing that data to build the content accordingly. This is another example of a university of Birmingham that really did exactly that, built a boot camp very specific for their population in coding and data analytics. It was funded by the government and to really help, in particular, women and people of color to land jobs. So real quick again, the 4 trends. So much broader adoption of online lifelong learning, the growth of modular and stackable learning, shift to blended learning on campus, and mapping learning to career relevancy. So I'd like to invite you to join our movement in whatever way, shape, or form you feel like it is. We have courses for government, courses for businesses. You can partner with us. We have our open source code available if you want to set up your own instance. So with that, I thank you, vielen Dank, and great work that you're all doing, and hope to see it more on the platform.
Thank you very much.